chairpersons for the session remain the same, but we have received a call from Dr. Prabha ma'am, who was supposed to take the first session. Madam is busy in the OT, so Dr. Gitanjali ma'am will be starting with her talk first. But I will introduce the chairpersons who are for the first session. And they will remain the chairpersons for this session also. So, we now begin with our scientific session for the 229th edition of the Happy Learning Masterclass. The topic being obstetric hemorrhage, as sir has already said, and which is an area of immense clinical importance and growing relevance. And I introduce our first chairperson. Can we have the CVs, please? Is the CV being shown?
Yes, ma'am. Yes.
Okay. So for Dr. Lata, our first chairperson is Dr. Lata B. Madam is, I'm waiting for the CV to appear. Please go. Yeah. So, Madam is a professor in Department of Obs and Gynae at JJM Medical College, Devangere. Madam has over 13 years of teaching experience and has contributed to several important projects, including low birth weight and infant feeding studies, labor care guide, and the Action 3 trial. Her areas of interest include high risk obstetrics, and she is well known for her dedicated academic and clinical contribution to maternal care. We welcome you, Dr. Lata ma'am.
Thank you, ma'am, for this opportunity. Thank you.
So our second chairperson for the session is Dr. B.K. Anupama Sundar ma'am. Madam is the Secretary of Bellary Obs and Gynae Society for 2025 to 27, that is in the current year running, and is a consultant obstetrician and gynecologist at BKS Hospital Bellary. With over 20 years of clinical experience, ma'am has also worked in United Kingdom at Sunderland Royal Hospital. She has several publications and has been actively participating in social awareness initiatives and has been honored recently with the FKCOG Fellowship in 2025. We welcome you, ma'am, to chair the session. And ma'am, can I request one of our chairpersons to be kind enough to please introduce Dr. Gitanjali, ma'am. So, Karuna, please, the second session speaker will be speaking first. Madam's topic is massive transfusion protocol. So can we have Dr. Gitanjali's CV, please? Madam, yeah. So can we request our one of our chairpersons to please introduce Dr. Gitanjali, ma'am?
Dr. Gitanjali is a professor in the Department of OBG at Nijalingappa Medical College, Bagalkot, former chairperson, Clinical Research Committee, Kasoga. She has participated in several completed and ongoing international research products in obstetric care, including prevention of preterm birth, antenatal corticosteroids, maternal and newborn sepsis, pre-eclampsia, adolescent nutrition, etc. Several research publications in national and international journals, faculty at state, national, and international conferences and seminars. And I have been part of the panel as a panelist when Gitanjali doctor was the moderator. So it's great to hear her today, and I welcome her to the CME today.
Thank you, ma'am. Thank you.
So thank you, ma'am. The stage is all yours. Karuna, please stop sharing the screen so that Madam can share her screen.
Yeah.
Ma'am, please take over.
Yeah. Is my screen seen?
Yes, ma'am.
Yes.
Yeah, okay. So at the outset, I thank the organizers, especially Dr. M.C. Patel, sir, and his entire team of dedicated coordinators who have put together this beautiful CME. Thank you for giving me an opportunity to share my views on massive obstetric hemorrhage protocol. So I bring greetings from my institute, S. Nijalingappa Medical College, Bagalkot. All of us have been faced with this kind of a scenario where you do not know what is going on. Everything is so bloody and it looks all red, and all sorts of thoughts are running in your head. What about ventilator? Is the ICU bed available? There's so much of chaos. Is the blood bank does this? Does it have this kind of a blood group or not? And so many things are going on within our minds. And perhaps if we have a protocol at this time to see that we go in an organized manner, maybe the outcomes are going to be much better for the patient. So what happens exactly when there is massive blood loss. Now, massive blood loss itself is defined in various ways. And perhaps the most practical one of them would be to say that there's ongoing bleeding of at least about 150 ml per minute, which is really, really a very large amount of blood being lost per minute. There are various definitions which we'll come to later. But when there is massive hemorrhage, then the immediate side effects are going to be tissue hypoxia, oxygen carrying capacity is decreased. Because of this, the anaerobic metabolism is going to start, and we have acidosis setting in, release of pro-inflammatory cytokines, systemic inflammatory syndrome, response syndrome, though I know that this is not a terminology which is used anymore, but it sets in something like this, which causes damage to all the organs, DIC, and ultimately we may end up in a maternal mortality. So what I would like to stress in this slide is, of course, all the cascade of events which are going to happen. And this will happen if we do not take action to see that the bleeding is stopped and to see that the blood is replenished as soon as it is lost. And ultimately, whether you are having an atonic hemorrhage or you're having a traumatic hemorrhage or whatever is the cause of the bleeding that the lady is having, ultimately everything is going to end up in coagulation failure. She will end up in DIC. And then we will be at a very, very critical stage beyond which perhaps the recovery is going to be very difficult. So it is logical. The patient is not losing only platelets, or she's not losing only RBCs. She's not losing only plasma. She is losing whole blood. And when the patient is losing whole blood, perhaps it's logical to say that, I'm sorry. Sorry, I went off to the wrong tab. That's on screen, yeah. So it's logical to say perhaps that we should transfuse whole blood. And I know that there are some people who still believe in this. So I just want to ask the audience whether you think, is my arrows working?
We can't see any arrows. We can just see what is written on the screen.
Nothing is moving, right?
No, we can just see this screen which says when the patient is losing whole blood, it is logical to transfuse whole blood.
Yeah. So I think I'll stop share and I will
Yes, ma'am. Please
share
reshare.
it again. Yes.
Yes, ma'am. Can we request the other doctors to please kindly mute yourselves?
Yeah. So when the patient is losing whole blood, it's logical to transfuse whole
Madam,
blood. And
please
this
make
is
it full screen, ma'am. Abhi slideshow pe
Huh?
aa jaye. Please make it
Yeah.
full screen. We
For
can
me-
see your thing, but it's gone to the first slide, which is the heading slide, and it's not a slideshow.
Okay. For me, it is showing slideshow. I'll just stop share again. And I hope this issue gets sorted out.
Yeah.
Can you see this screen now when the patient is losing whole blood?
No,
No?
no, we can still
Again, the
see
first
just
slide.
the first slide, and
Oh,
that's it
Yeah.
is stuck on the first slide, and it's not the slideshow.
Yeah. I did something wrong.
I think something on the top, like a design or something, has been clicked by you on the
Let me
PPT.
see. Now can you see full
Yeah, yeah.
slide?
Yeah.
Yes, yes.
And am I at the right slide now?
Yes.
Yeah. Now, can you move this forward, ma'am? Next to the next slide. Yeah.
It said right?
Yeah, it
Yes.
says right. Yes.
Yeah.
Now
So
it's
is it right? I hope everybody says no, it's not
Yeah,
right.
right.
It is wrong. So we are
Yes.
supposed to not replenish with whole blood because there is a lot of logic which goes behind that. So I know that all of us are in the era of component blood therapy, and of course there are so the component blood therapy has got a lot of benefits. And why exactly these benefits are there is because if you understand this test tube of blood that you have maybe centrifuged, and then you have seen that all the erythrocytes are at the bottom, and we have the buffy coat, which is the leukocytes and the platelets in the middle, and the plasma, which is the major component of the blood at the top. So similarly, looking at them as to the requirements of storage of each of these different components. So packed red cells, maybe they're available in packets of about 200 to 250 ml. And the hematocrit per se of that packed cell, which you get from the blood bank, will be about 70%. It raises the HB by about 1 to 1.2%, depending on what is the volume of the blood which is drawn from the donor. So we have both 350 ml bags, which then converted to components, or we have 450 ml bags which are converted to components. So depending on that, obviously the amount of blood is that you're transfusing is different, and hence the HP is also different, the raise. Now the important thing is that this is to be stored at 1 to 6 degrees Celsius. This is the same for whole blood also, and for packed red blood cells also. And the shelf life, depending on what is the anticoagulant which is used, can vary from 21 to 35 to 42 days, each depending on the three different types of anticoagulants that can be used. So what is important in each of these is that the platelets, which are basically going to be giving us platelets, they are to be stored at 20 to 24 degrees Celsius. So obviously, if I'm going to store at the red blood cells at 20 to 24, I'm going to have a destruction of the red blood cells. Whereas if I store the platelets at 1 to 6 degrees, then I'm going to have a destruction of the platelets. And another important way that the platelets are stored is there has to be continuous agitation. So if you have gone to the blood bank and seen, they have something like a plate, a horizontal plate, on which the platelet is kept, and it is continuously in motion like this. So that is going to be help the platelets remain viable. And the shelf life of these platelets is only 5 days. The fresh frozen plasma is basically the plasma which is then frozen. It contains majorly the clotting factors and protein, and it is stored at minus 18 degrees Celsius, and it can be literally used for 1 or 2 years. And anytime there is a requirement, this the frozen plasma is thawed, and then it is issued for the patient, and then can be used for the patient. So each of these blood components, of course, we can get cryoprecipitate, we can get single donor platelets also from the blood bank. The storage conditions for those will be similar. Fresh frozen plasma and cryoprecipitate are similar. STP and RDP are similar. Whole blood and packed red blood cells are going to be similar. So if I keep whole blood for about 10-15 days in the blood bank, and then I issue it thinking that I'm transfusing all the components of blood, then I will actually have only the RBCs which are still viable and which are going to give benefit the patient. Whereas the platelets and the clotting factors are already out, and so the benefit of that is not passed on to the patient. Now, what is the advantage of going for component blood therapies? Obviously, it allows optimal survival of each component of the blood. It allows transfusion of only what is indicated, and it avoids use of unnecessary component which could be contraindicated. For example, whole blood. It may just give a volume overload to the patient, a patient who cannot actually handle that much of volume. And one donor might potentially be saving lives of several patients. So these are all the advantages of component blood therapy, and that is what we should be doing as we go faced with the major hemorrhage. So I'm going to go through a little bit of a complicated scenario. This is being put together by the Jeeva Raksha Trust. I'm sure everybody in Karnataka knows about Jeeva Raksha because all our medical institutes have got tie-ups, or rather we are under Jeeva Raksha for our ECLS training. And this is the same Jeeva Raksha which has put together this major hemorrhage protocol. You can see that it has been, it is color-coded into different parts of the chart. So the pink one is urgent, then I would call it red is assess. The orange one is respond. The green one is reassess every 60 minutes. And the last thing in blue is sort of some general information which is present at the end of the chart. I would highly recommend that this kind of a protocol is printed out and put in the labor room, which helps somebody who is on the floor and managing a critical patient. Now coming to the pink, I'm going to just highlight, I'm going to sort of focus on each different component of the major hemorrhage protocol to see what it exactly says. So the pink part, that is the urgent part. First of all, recognize that a woman is having major hemorrhage. As I told you, there were different definitions of major hemorrhage. One of them is if there is more than 1500 ml blood loss. Now this varies according to different textbooks and different guidelines. Some say even 2000, some say 2500. But 1500 maybe taking a lower cutoff would be better so that we actually start action earlier. Or if there are signs of shock, or if there's ongoing bleeding of more than 150 ml per minute. And this should be assessed in a better way by a quantitative measure rather than just by eyeing the amount of blood which is lost. So this could be something like it is said that the obstetrician always underestimates the amount of blood loss, and the anesthesiologist always overestimates the amount of blood loss. So if you actually have a quantification, it would be good for the patient care. So if in case I'm not able to handle this patient in my institute, I would transfer, hopefully with 2 units of PRBCs and by putting on the non-pneumatic anti-shock garment if I have to transfer. But if I am able to handle such a patient in my unit, then I should activate the major hemorrhage protocol. So I think the way we, every morning when the garbage tractor comes along with all songs and all that. And the minute that comes, we drop everything that we're doing and we pick up the dustbin and we go running out and keep it so that it gets taken with the garbage. Similarly, as soon as we have some such kind of a hemorrhage occurring, we have a patient who's having this kind of a problem, we should activate the major hemorrhage protocol team, which has all been assigned some tasks. Now, these tasks run simultaneously. The first one is to initiate the resuscitation. Second one is to identify the cause. And third one is to get help to stop the bleeding. Now, though I said first, second, and third, these are all going on simultaneously. None of them take precedence over the other. All of them have to be done simultaneously. So we run the emergency code. We rapidly identify which of the four T's is causing the hemorrhage, and we have an ongoing communication with the team and the relatives. So this is the first part of the chart, which says what we should do urgently. Now coming to the red part, that is the assess. So we should have a team leader who is assigned. If everybody on the floor is doing things, whatever they feel like at that moment, one person is catheterizing, one person is doing oxytocin, one person is doing bimanual return compression. So nobody has a sense of what exactly is done as a whole for this patient. So it's better if one person who's got a clear mind who's standing outside the chaos and telling people what has to be done. And as soon as that person says, give oxytocin, for instance, the nurse or whoever is doing it should come back and say, I have given the oxytocin. So in this way, the team leader will better be able to have a sense of what has been given, what has not been given, what is the next task to be done. So that person will also assess the airway, breathing, and circulation and assign the tasks based on that. Collect blood for CBC, cross-match, and DIC profile, renal function tests, and the serum calcium. Also on the chart, we have the different colored vials which are to be sent for each of these different tests. So this is the second part of the chart, which also says that we should have one person who is nominated exclusively to liaise with the blood bank. So tell the blood bank that I need 1 unit, I need 5 units, I need 4 units, I need FFP, I need platelets. All this ongoing communication, instead of somebody running each time to the blood bank, you have one person who's constantly talking with the blood bank and also reassuring the relatives or getting them to do whatever is the thing that needs to be done that particular moment. Now coming to the third part, which is respond. So as soon as the patient is having, either she is delivered in my institute or she is having this ongoing bleeding antepartum or postpartum in my institute, I will not have blood ready as soon as it starts. So crystalloids, 2 liters of normal saline or ringer lactate can be administered under 30 minutes. No question of an overload if you're really having massive hemorrhage, because already patient is in shock at this moment. And beyond 2 liters, if she's still not out, then we can continue at the rate of 200 ml per hour. So first crystalloid replenishment can be done. Administer 1 gram of tranexamic acid in 10 minutes. This is a WHO guideline that if, whatever is the cause of the bleeding, whether it's trauma, whether it's atony, or whatever is the cause of bleeding, tranexamic acid will help if it is within 3 hours of the onset of bleeding. Once it goes beyond 3 hours, as I already said, everything ends up in coagulation failure, and then giving tranexamic acid in that scenario is not going to help the patient. At this point, we ask for, from the blood bank, we ask for the major hemorrhage package 1. Now, major hemorrhage package 1 contains 4 units of PRBC and 4 units of FFP. The important thing here is that we have to have a 1:1 ratio, and unless the patient outright, we know that she has got a platelet count which is low, perhaps right in the beginning, platelets is not required for every patient, and we can wait for the issuing of the platelets later. 4 units is to 4 units. Western literature also says 6 units is to 6 units, but it very often happens that some of the blood goes waste, and already having a resource limited setting like us, so we can take a call as to how many units we should ask for at a time. But whatever it is, when we are having major ongoing hemorrhage, at least 3 units and simultaneously 3 units of FFP also. So 1:1 ratio we have to get. And get the lab results and continue checking the lab results every 60 minutes to see if there is any ongoing deterioration. Now, what could be the lab results? So the lab results will tell us the HB, the PT, PT-INR, APTT, fibrinogen, platelet, and serum calcium. These are the things that we're interested in. Now, talking a little bit about the HB, we are not worried about what the HB is if the patient is in shock. Sometimes, many times a resident rings up and says she's looking papery white, but her HB has come out as 8.5. And then they take it cool beyond that because it's not such a critically low value. But obviously the HB takes time to change to reflect the actual circulatory situation. And so giving a high HB should not be taken as a reassuring way, but a low HB definitely means that she is really critically ill and we need to transfuse. For this, we need PRBCs. If the PT, APTT or PT-INR is affected, it's fresh frozen plasma. If the fibrinogen is affected, if we do have a blood bank, like my blood bank does not give us cryoprecipitate unless we specifically ask them to prepare it and it is elective sort of, it doesn't come as an emergency, then we can go for cryoprecipitate, two pools of 5 units. But if we do not have cryoprecipitate, we can again give more amount of fresh frozen plasma itself. If the platelet comes less than 50,000, then we need platelets as even in this initial management scenario. And if the serum calcium comes low, depending on what your lab uses, whether it is milligram per deciliter or millimoles per liter, if the serum calcium comes low, then we're supposed to give 10 ml of 10% calcium gluconate over 10 minutes. So all of us know that the RBCs are they have anticoagulant, and that causes a decrease in the calcium, and decrease in calcium can again cause more chances of coagulation failure and more hemorrhage. So though it is not given as a textbook guideline or not given in any standard literature as to after how much time, like some people have this strict protocol that if you are given 2 transfusions, then give serum calcium and they give calcium. But that is not a standard guideline from anywhere. Perhaps practically speaking to some experts who manage, especially the anesthesiologists, and maybe if Prabha madam had already spoken about PAs, then we would have seen such a horrific condition, because that is the most common cause of really, really massive hemorrhage that we see nowadays. Then in those cases, they usually after about 3 units of PRBCs, they do go for administration of serum calcium. But ideally, we're supposed to see the ionized serum calcium, and based on a low level, only then we're supposed to go ahead with the calcium administration. So this part talks about the respond of the chart. Now the last one is reassess. That is every 60 minutes we have to go ahead and reassess. Now there are some goals that we want to achieve. So we want to get her systolic BP up more than 90 millimeters of mercury minimal. Repeat and review labs and see that they are stabilizing, and there should be no ongoing bleeding. So these are the goals that we have to achieve, and the question we ask ourselves is, are these goals achieved? If the goals have not yet been achieved, at this point of time, I get in platelets also. So that is, I ask for from the blood bank the major hemorrhage package 2, which contains 4 units of PRBC, 4 units of FFP, and 4 units of platelets. And at this point, if her BP has still not picked up to more than 90, then we can start inotropes, and the preferred inotrope is noradrenaline. Reassess, goals achieved, not yet. We keep going down this loop. And then we have to see that simultaneously, as I already told you, somehow or the other, the bleeding has to be arrested. Now, if by chance these goals are achieved, we have actually been managed to get her to a stable state, then we can only go for maintenance fluids, normal saline or ringer lactate at 75 to 100 ml per hour. Refer to a specialist unit or hospital if mine is not the one, or if I need to shift to ICU in my hospital itself, shift to ICU, etc. And during transfer, always consider the use of non-pneumatic anti-shock garment. So this is reassess every 60 minutes, that part of the protocol. Now the last one is just actually general considerations. Start 2 peripheral IV lines, 14 gauge, orange preferably, or at least if not, we should go for green. Check temperature every 15 minutes because cold coagulopathy also kills, so prevent hypothermia. Check the labs, LFT, RFT, HbSAg, HCV, HIV, and some of these conditions might have separate treatment goals, and we have to consider those in those special conditions. Maintain a high index of suspicion for venous thromboembolism. So this patient, any patient, obstetric especially, who goes into shock, recovers, and then is stable, these patients are very likely to go in for thromboembolism later. So we should consider thromboprophylaxis for these patients after they have stabilized, obviously not when she is bleeding. Recognize a high risk of acquired infections. All of us are doing 10 things together, not very, very careful about the asepsis. So maybe cover with broad spectrum antibiotics. And before we increase the intravascular volume, we should not start with noradrenaline. First, give the rush of the fluid and then start noradrenaline to achieve a mean arterial pressure of about 65 millimeters of mercury. Also, this chart has got some local phone numbers to be written over there and pasted on the wall. So, emergency response team. It's better if there is the same team which comes in every time, because they already know, they have a set protocol of how to do it, which may be logistically challenging. The blood bank numbers, whom I need to contact when I need so much, maybe the blood bank officer has to be directly contacted or whatever. Laboratory numbers, and if you have a hematologist, then their numbers. So this is the last part of the chart. So again, this is the entire chart. If it is useful, then you can think of modifying it as per your requirement and changing it whatever is required in your thing. And it would be good if it is put up in the labor room as a protocol for everybody. Take home messages: when faced with major hemorrhage, use the major hemorrhage protocol. It's useful to have an identified response team so that they are already well versed with their team actions. Volume expansion with crystalloids before the use of noradrenaline. If there is no intravascular volume and we start noradrenaline, there's nothing for the heart to pump, so it doesn't actually make much sense. Early use of fresh frozen plasma in major hemorrhage saves lives. And this actually, maybe I should have told this right in the beginning, as to why we think that FFP has to be brought in whenever there's major hemorrhage. This is actually a learning from war scenarios. So when there is injuries, of course, massive injuries in war, they have been the ones to tell us, so maybe from surgery we have learned that fresh frozen plasma being introduced early in management of hemorrhage actually saves more lives rather than waiting for the coagulation failure to occur. Tranexamic acid to be used within 3 hours of the delivery, irrespective of the cause of PPH. It is not only for traumatic. Every kind of PPH will be better because of tranexamic acid. There is an emerging role of recombinant factor 7A, and I'm sure the panel will guide us more about this. And during transportation, either from my hospital to another, or even within my hospital, some amount of delays if they are there, then use of an NASG will cause a more stable patient. I'm sure this also the panel will tell us. Just as a pictorial depiction of how the non-pneumatic anti-shock garment will help. It prevents peripheral pooling of blood and directs it towards the more vital organs so that we have a more stable patient in the end. Thank you all.
Thank you, Dr. Gitanjali. I mean, that was very useful and very concise management of massive transfusion protocols and massive postpartum hemorrhage. Chairpersons for any feedback.
It was a very nice talk and very informative talk about that Jeevaraksha. I think everyone should put in the labor room actually protocol. Thank you.
Thank you, ma'am.
Yes, excellent talk, very clear-cut points, protocols. I think somebody who has heard her will have so many things, clarity which she has driven home. And the thing about NASG garment also, I think every hospital should actually buy and keep one, because we don't know when emergency will land. So that was an excellent point. Congratulations on your talk.
Thank you, ma'am. Thank you.
Thank you once again, chairpersons and Dr. Gitanjali. Do we have session 3 now, session 2? Yeah, could we move forward? Moving on to the next session, and the next session, for session 2. The chairpersons for the same are Dr. Jyoti, sorry, this thing is actually, my net is very, Dr. Jyoti Patel, Dr. K. Vishwanath, and Dr. A. Savita. Dr. Jyoti Patel is the President, Ballari Obs and Gynae Society. Could we have a CV, please?
I've given only so
And
much
she's
marketing every
No. What was very interesting in your CV was about your postpartum hemorrhage. That you've got the Ballari chairperson for the massive transfusion protocols. Yes. That was something which was very interesting in your CV. So that's why I wanted to just make a special note of that point on your CV. The next chairperson, Dr. Davangiri. His focus is on maternal and child healthcare services and leadership and community services, and current role is in Sri Mrityunjay Healthcare and Nursing Home as well as in Amruta Hospital. And the third chairperson for the same series, Dr. Savita. please, her CV. The next CV, please. Right. Dr. A. Savita is the assistant professor at Bidar Institute of Medical Sciences, and her special areas of interest are infertility as well as cosmetic gynae. And she is been the organizing secretary of Kasoga Zonal Conference 2025 and conducted and assisted workshops on SR cannulas as well as medical legal aspects of OBS and gyne, Sampurna Swastha Jan Abhiyan. Over to the chairpersons to introduce the speaker for this session. Dr. Jyoti.
Good evening, everyone. It's my pleasure to introduce Dr. Prabha Desai. Can you please share the CV? Dr. Prabha Desai is from Karnataka, Gadar. I'm also from Karnataka. It's my pleasure to introduce Dr. Prabha ma'am.
Session 2, yeah.
Yeah. Dr. Prabha
Dr.
Desai
Prabha
has done
Desai.
MS, FCPS, DGO, PGDM, LS, and DIP gynec endoscopy. A lot of degrees in a credit. And she is a consultant OBG gynec at her gynec endoscopy. Dr. Desai Memorial's multi-speciality hospital. She's the endoscopy surgeon, and her professional affiliations are Kasoga Endoscopy Committee Chairperson 2025-27, lifetime membership IMA, FOXY, IAG, ISAR, GOGS, and the 2 times elected president Gadag Obstetrics and Gynecological Society. She has got various awards, to name few. Suvarna Sadaki 2026, OBG Pillars of Progress Award by SOGYS 2025-26, IAG Excellent Skill Young Star Award in MIS in Gynecology 2023, First Prize Best Poster Prize in PISAR 2019 Conference, and Best Academician Award of Gadag Obstetrics and Gynecological Society 2015 and 16, FOXY IAG Star Eagle Award 2025, Golden Jubilee Award, Mumbai. Welcome, ma'am, Dr. Prabha Desai.
Thank you, ma'am. Thank you for the kind introduction. I think at the outset, I would like to thank Dr. Patel sir and Monica for giving this opportunity to start the to give this talk. Can I share my PPT?
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah, I'm just share option, share screens. I think somebody else is managing this.
Ma'am, if you just open your presentation first and then click on the share screen.
Usually
Tech support, have you given ma'am, Prabha ma'am screen sharing rights?
Yeah, screen sharing only. Select a window or application if you want to. I will. It will not come from ScreenShare. Share
No,
set.
Madam, first keep the PPT open.
Okay. Yeah, I opened the PPT.
Then you say share and then it will show you what all is open. So go to your PPT.
Yeah. Share, but where it is showing save to cloud. Share.
No, ma'am, you don't have to share to cloud.
Shares in the Zoom, madam, green button.
Share in the Zoom.
At the bottom of your screen, there's a share button, green color. No?
No, it's not happening. That's why.
Maybe she doesn't have share rights.
No, I have. That's why. Usually.
Next to mute the
Madam,
mute video participants.
Madam, you joined through faculty link only, no?
Yeah. I think I am visible now, right?
And you are visible, you are audible.
Yeah, but
Absolutely.
here some share is there, but it is not getting share. Pooja,
Just double click it, ma'am. Just double click it.
remove pin.
Tech people is have you made just does ma'am have screen sharing rights?
It's showing everything recording, share option, share sound, optimize video sharing. Wait, 1 minute. Pooja? Yeah, share.
Who's there from the tech side?
Allah, here is a share button. See, you're joined through faculty link, Allah. Or join actually share screens anta run anything is seen shares. Wait. Yeah. Is it shared?
Yes.
Hello?
Yes.
Yes, ma'am. Now it is sharing.
Full screen.
Okay, sorry, this is something different. Usually once only I share, it will get shared. I don't
No,
know.
no, fine. We can
Is
see it.
Yeah.
Now you can make it full. If you can make it full screen, that would be wonderful. But even with this, it's so fine.
Yeah, yeah. Yeah, yeah. I will make a full slideshow. Okay. Is it seen?
Yes, ma'am. Yes, ma'am.
Yeah, yeah.
Perfect. Perfect.
See,
Thank you, ma'am.
even though this topic is very old, that is placenta previa syndrome, but it is coming in very high rates and with in variety of presentations, because of increasing cesarean section rates and increasing so many of minimal invasive surgery or so many of surgical fertility enhancing surgeries and all in hysteroscopy, laparoscopy, these are all things whichever are damaging our endometrial layer or myometrial layers. These all are increasing this scenario of placenta accreta syndrome. So it requires always revisiting these kind of life-threatening conditions. So aberrant placentations, everybody know, is an abnormal implantation or invasive or a adherent placenta. So derivations of accreta comes from Latin. Actually, it is called as a crescent, to adhere or become attached to. So we know that when it is normal, it is only pertaining to the endometrial cavity. And when it is accreta, it is less than 50%. Increta, more than 50% invasion. And percreta is going beyond the outside of the endometrial cavity. Outside the myometrium. So its incidence, as I said, it is increasing nowadays because of increasing so many of operative procedures. And it is all, I said it is directly proportionate with the increasing rate of the having a placenta accreta. So if we everybody know that there are tropoblastic villi which covers the placental villi and which is made up of cytotrophoblast cells and the syncytotrophoblast. But extravillous trophoblast which arises from the distal tip of the villi anchor this extra vascular trophoblast will differentiate primarily into interstitial and endovascular cells. The interstitial cells invades the uterine wall as far as the inner third of the uterine myometrium, and which is everybody know it is called as junctional zone. And in the invasive of invasive placenta accreta syndrome, these EBTS can be found beyond the junctional zone and the chorionic villi inside myometrial vascular spaces. This leads to the absence of the normal plane of cleavage and prevents the placental separation after delivery. So this, everybody knows that the Nistabuch membrane is a very important membrane, okay, which prevents this decidual invasion, okay, into the myometrium. And we always do this correlation of our niche or anterior placental implantations in case of placenta previa is more dangerous, and in case of previous LSCS cases, why it is increasing? Because of this, if we take Nitabich membrane is absent in the lowermost part of the uterus. Okay, if our incision goes there, then this healing will not be proper and complete. So this will cause a this will cause a direct invasion of the placenta, and because of absence of this Nitabich membrane. So molecular biology of placenta accreta syndrome is a complex process which is divided into angiogenesis, proliferation, and inflammation. So these all are the molecular level changes happens, and that will lead to the placenta accreta spectrum. See, can we do some biomarker test which can predict or which can tell about the placental diseases? Yes, nowadays we all are seeing that PAPA, PAPPA, and these maternal serum alpha-fetoproteins, if we do during, along with the double marker test and all, that can be correlated with placental insufficiency also, and some form of other maternal cells, free beta HCGs, myometrial fibers into the basal plates. This all, if we study, we can we can predict some aspects of the placenta accreta syndrome. Okay, so if we go to the etiology, it's a lot many factors are involved in this. That most important is a defective endometrial myometrial surface, abnormal decidualization, deep placental anchoring villi and tropoplastic invasion, cesarean scar pregnancy, and the risk factors involved for this are usually Savita. These factors involved are placenta previa, previous cesarean sections, particularly with the placenta previa, assisted reproductive technology or in vitro fertilization, previous history of placenta accreta, previous history of retained placentas, previous
Indian
uterine
tablet and
artery
bed
embolization
ನೀರು
for
ಬಿಟ್ಕೊಟ್ರು
postpartum
ಎರಡು ಮೂರು
hemorrhage,
ಸಾಕು
previous
ಅಷ್ಟೇ
operative uterine
ನಾರ್ಮಲ್ ಮುಖ
procedure.
ತೊಳ್ಕೊಳ್ತೀವಿ ಅದೇ ನೀರು ಬೀಜದ ಜಾಗ ಸ್ವಲ್ಪ ನೀರು
Hello.
ಬಿಟ್ಕೋಬೇಕು ಎರಡರಿಂದ
Hello.
ಮೂರು ಆ ಜಾಗ ಸ್ವಲ್ಪ ತಂಪಿದ್ದಷ್ಟು ಸ್ವಲ್ಪ ಒಳ್ಳೆ ಕ್ವಾಲಿಟಿ ಸ್ಪಾನ್ಸ್ ಪ್ರೊಡ್ಯೂಸ್ ಆಗ್ತದೆ. ಸರಿ ಐತಿ, ಏನು ವರಿ ಮಾಡಿದ್ದೀನಿ. ಸರಿ ಓಕೆ. ಬೇಡ ನಾಳೆ ಬಿಟ್ಟು ನಾಡಿದ್ದು ಬರ್ತಾರೆ.
Hello. I think somebody is talking in between. I cannot concentrate. Can you mute the others? Hello. Can you mute the others? Hello. So whenever the age advances, the placenta accreta syndrome chances increases. So previous dilatation and curettage of the uterus, maternal smoking, uterine synecdoche or Asherman syndromes, previous endometrial ablation, previous uterine fibroid embolizations, or any intervention. Hello. Is a cause for placenta accreta syndrome. Hello. Am I audible?
Yes, madam, you are audible. You can continue.
Actually, this something has happened. My slides are not moving only. I think somebody has. This is, I don't know what has happened. It is visible. Hello.
Ma'am, slide of maternal age is seen.
But slides are not moving here.
Yeah, slides are stuck, madam.
Yeah. Shit.
Any, you can continue your session, madam, from your like parallel. You can see. I feel.
See, actually, no. Just I wanted to show some new things of management of placenta accreta. This is all actually, yeah, it is now moving. So first and second trimester, see, everybody know what are the clinical presentations. Usually in first and second trimester, they may present with spotting PV or menorrhagia, the hemorrhages, and ultrasonography. If you see, there is the most important factor in outcome. If you do antenatal diagnosis, that will give us a best, intraoperative or antenatal diagnosis. In early stages, will give us a very good result while we are managing to the patients. How we will see further. So if you want to diagnose such cases early, ultrasound is the best thing. Actually speaking, early stage, like a first trimester scan itself may predict whether this patient will go into placenta accreta syndrome or not. And that is most possible if you see where is the gestational sac implanted. Usually if it is implanted in the lower part of the uterus and in the anterior segment, and that to previous cesarean pregnancy at the scar sites, then you have to see what are type of the implantation, whether it is growing. Serial scans will show whether the gestation is growing inside the cavity or it is the implanted site is at this exact scar site or just above or below, and that we can predict and counsel the patient at the same time. Then the color Doppler, MRI, biochemical markers, and histopathology. See, as we say, the transvaginal scan is a most sensitive for confirmation of this. And if you are strongly suspecting the ultrasound is giving you a proper picture and you are strongly suspecting on ultrasonography, there is no need to do the MRI. So abnormal placental lacunae, what are the findings? If you see there may be abnormal placental lacunae or placental legs, loss of retroplacental hypoechoic space. That is, usually we see there is a hypoechoic subplacental vascular space. If that space is lost, then chances of accreta are there. Abnormality of uterus and bladder interface. Okay, like too much of bulge of the uterus inside the bladder or focal exophytic mass. If you see that placenta tissue is breaking through uterine serosa and extending beyond it, these all are the telltale sign of the placenta accreta. Okay, then myometrial thinning. Nowadays, everybody reaches the RMT. If the RMT is less than 1 millimeter or it is undetectable, then you can predict the accreta. All USG features are present from second trimester. Okay. Thus, effective screening is possible at anomaly scan, thereby allowing definitive prenatal diagnosis by 28 weeks of gestation. So these all are the signs what I have told yet till now. That is a retroplacental zone absent, and then the huge placental legs. Okay, then multiple lacunae. Visually, we call it as a moth-eaten or Swiss cheese appearance, which is very famous sign. Obliteration of retroplacental hypoechoic areas. And color Doppler, of course, is added things and which will give us a definitive confirm our diagnosis and how vascular invasion is, how much it will predict the intraplacental venous leaks or subplacental retrovesical hypervascularity, everything will be studied by color Doppler. MRI, it is used as I said, only I recommend in two conditions: when the placenta is posterior and you are suspecting accreta, or then MRI is the best. And it is used as please, can you mute the others? Organizers, can you mute the others? Hello. Hello.
Not able to hear. This
Please, Dr.
Karuna,
Pallavi,
please
can
tech
you mute
support, please
yourself?
mute others. Please mute everyone except the speaker.
It's quite nuisance, while talking somebody is. See, MRI pictures is recommended when a USG findings are equivocal or posterior placentation. And second thing is when you are dicey on the USG, when you are dicey on the USG, whether it is accreta or percreta or it is just adherent, then better to do MRI. Or in case of twin pregnancies, multiple gestations, there also you can go for MRI. And what you should ask for that is T2 weighted images, okay, and that is more specific for the placental invasion, and we can accurately diagnose how much it is invaded into the bladder, whether it is located inside the niche or any pouch is formed. These all things we can make out. Okay, these all are the placenta, accreta, and see, this is placental septi. See, these are minor things, sagittal oblique MRI, which is showing triple layered platter of the placenta. Okay, so all fine details we can study on the fetal MRI. Sorry, this obstetric MRI for placentation. Usually we do at 28 weeks to 32 weeks for confirmation. Okay, then complications, massive hemorrhage, blood transfusion, risk of hysterectomy, lower uterine tract damage, and infections, maternal mortality. Everybody knows if one patient of placenta previa or central placenta previa or placenta accreta patients have enrolled with you, means it is a nightmare for the doctors also, and they should be ready to manage all these complications at any time patient comes with heavy bleed or in APH. So morbid adherent placenta or placenta accreta syndrome, how we should go antenatally. So most important thing is maintain their hemoglobin and be ready for delivery at any time. So at 32 to 34 weeks, give them steroids. At 32 weeks, do the placental study again by ultrasonography, or as I discussed now with the placenta MRI, and counsel them properly. Okay, that they will require blood transfusions during they may require a blood transfusion during their delivery or at any emergency. So whatever their blood group is there, they should discuss among their relatives and keep some donors also ready. Whenever they are in need, they can call them for the blood transfusions. Then anti-D immunoglobulins in case of bleeding. If it happens frequently at 28 weeks, better to cover them. Then NST is and BPS not a routine practice, but used when the standard indications are present as per the other cases. There is no role of regular NSTs or biophysical profiles. No PV examination. Everybody know this is like a post-graduation students, that you should never do a harsh PV. You can do a single gentle PV if whenever you are suspecting. So detailed counseling on maternal fetal risk, blood transfusion, need for hysterectomy, interventions, radiology helps if it is available at your center, and the cost of management of these patients will not be as will not be like comparable with the other low risk patients. So we should tell them that they should be economically also be ready when for their any emergencies like ICU care, blood transfusions, and all kind of major surgeries and interventions. So major placenta previa should be kept close to the hospitals, or you should tell them once they are having any bleeding episodes, or at 34 weeks better to be admitted in the hospital and monitored. So as per NEC guidelines, if the placenta is less than 2 centimeter nearer the internal os, it is considered a low-lying placentas, and we should repeat the TVS at 32 weeks of gestation for its location. Persistent low-lying placenta or previa at 32 weeks in asymptomatic woman, and additional TVS at 36 weeks is recommended to inform about the mode of delivery. A short cervical length on TVS before 34 weeks of gestation increases the risk of preterm delivery and massive hemorrhage and cesarean section.
Have you seen your Lego?
Yeah.
Did you like it?
Oh shit. Please. Prenatal care, as I said, you should, these all kind of patients should be delivered in a institution only. Okay, so time of delivery, if there is no any other complications happen, so better to be drag them up to 37 weeks, and then planned cesareans is always better than the emergency care. So plan your delivery, keep adequate blood, and then do a proper counseling, take high risk consent, and then only go for, and see that all the helping team is nearby, blood and everything, blood products are available on that day, and then only plan for the cesareans. So if you go for the management, conservative management, extirpative treatment, expectant management, one-step conservative surgery, and triple P procedures. These all are the conservative managements. Nowadays discuss a lot about the triple P procedures and one-step conservative surgeries. Everybody knows that when all these method fails, you should aware that if PPH is there and patient is sinking, go for obstetric hysterectomy. Okay, don't go on trying on. Life is more important than just saving the uterus. We want, our main motto is save the patient. Okay, so what is the extirpative approach? The procedure consists of manual removing the placenta to obtain an empty uterus. Extirpating approach with a forcible manual removal of the placenta should be abandoned unless there is a low probability of placenta accreta syndrome. Okay. Then there you may need this extirpative approach. You may need some additional procedures to control the bleeding, like placental basement sutures or breast sutures, or you may need SR cannula to keep for 24 hours by aspirating, keeping the cavity collapsible, or the Bakri balloons to compress the placental bed. Okay, it is only possible where it is very minimally adherent placenta or at very small site. Then expectant management is leaving the placenta in situ without hysterectomy. Okay, this I have tried long back in one patient where the placental bunch chunk was very much adherent, and I just tied the umbilical cord and left the remaining placenta inside only. And we actually giving, after leaving the placenta, giving methotrexate or not is very debatable nowadays. So that time we used almost 10 years back, I had given her prophylactically a methotrexate and followed her every 15 days and 1 month. And then I could actually save her uterus also. I could save her uterus, and she took almost 3 months to expel whole of the placenta. We managed her by repeated Doppler studies, or and how much bulk of the placenta is remained inside. And actually she recovered well, and that was a successful. But until and unless you are sure that that patient, and you have to give a very high dose of antibiotic for a long term so that she will not go into the sepsis. So that is one more thing we have to keep in mind, and we should educate the placenta when you are living inside that whenever she feels the heavy flow, she should approach a doctor immediately. Okay. So this is intentionally retention of placenta, and when you are retaining it inside, you should not give her oxytocin. Okay, and you should confirm that patient is not having active bleeding, and then only you can leave it inside and close the uterus. And as I said, the disadvantage is the patients may go into sepsis and it will take a longer time to empty the uterine cavity. Usually, no need of actually serial beta HCG monitoring, but you can do a serial ultrasound and Doppler studies to see how much is the placental beads remaining. These all are the conservative management placenta previa studies, whatever recommended till now, and comparison of each. Okay, like leaving the placenta, explorative approach, then conservative treatment by doing methotrexate should be given or not. These all are the comparative and recommendations of each or the other. And actually, we should select the method as per the patient's. Individualization of the management is very important. Okay, and whatever that patient is needed, we should try for that. And ultimately, everybody should, I told that don't hesitate to go for obstetric hysterectomy if the patient is sinking. Okay. Then one step conservative surgery is this strategy aims to combine the advantage of leaving the placenta in situ approach and a cesarean hysterectomy. Okay. Also, because if you try to take out the placenta, there is lot much of bleeding may happen. And if you feel that you could not manage that bleeding, so better along with the placenta, you don't try if it is like a percreta, increta or very vascular, don't try to take out the placenta. Along with the placenta only, you take out the uterus. So once you take out the baby, you just close the uterus and then do the obstetric hysterectomy. Then this is a one see, this is one, that terminology I have only decided. And see, this is congru, that is Latin word. Congruous meaning fitting, suitable, appropriate, harmoniously sitting inside or corresponding well. See, this is a, nowadays these scenarios are increasing. This is actually a niche, and in this niche only placenta has got implanted, and this patient has presented to me as a central placenta previa at 37 weeks of gestation. I really wondered that patient has only one living issue, and this was a second pregnancy at 37 weeks of gestation. We thought of it is actually only placenta previa, but it is a retrospective diagnosis, central placenta previa, where the placenta was inside this myometrial pouch, which is a congru pouch. Okay. See, this is one small video of 5 seconds. Here we went by higher approach, incision, and delivered the baby. And then as one step approach I wanted to try, so I took out the placenta. But if you see here, after taking out of the placenta, I could see that there is a lot of much of bleeding, but there are two flap-like things. This is one flap and this is one flap. And actually the placenta was inside this. Okay. And not only anterior, this is a posteriorly also that flap-like pouch has gone inside. Okay. And this actually he was having this only one live issue now, and by seeing her hemodynamic status, we decided to obliterate this pouch. Okay, so this pouch has been obliterated in 2 layers. Okay, this is actually main cavity, and this is the flap-like. Her endometrium has become a flap-like thing, and there is a pouch where inside the myometrium was there. Then after closing the procedure, everything, we have done an internal iliac ligation for prevention of her secondary PPH, if any kind. Bilateral internal iliac ligation has been done, and tubectomy has been also suggested by the relatives, saying that her first pregnancy was also very dreadful, and seeing her this thing, see what I have learnt of this case is that we have saved this uterus with 2 pins of blood. Even we have 2 pins of blood and 2 pins of FFA has been given to her. She required 2 days of monitoring at the ICU, and she has been discharged on the 5th day without any bladder bowel complications or without any problem. Okay. But if you see, this is a very abnormal kind. First, we have to see where the pin has been localized. Even though it is not embedded the myometrium, okay, it is inside that pouch which was causing the bleeding. So once we obliterated the pouch, we could control her bleeding. Okay. So this kind of new scenarios are also coming up. We have to know how this phenomenon is happening and why this is happening. And then we should manage the root cause of that thing to prevent the recurrence. So everybody is now very much this triple P procedures. Our own Dr. Mrutyunjay Bellat sir is doing this procedure very much, and he is propagating this procedure a lot. This is actually a team of Chandraharan proposed a novel uterine sparing procedure by triple P method. In this, first P is preoperative placental localization and by transabdominal scan so that we can decide the superior border of the placenta where we can take the incision and deliver the baby safely. It may go into the anterior upper segment of the uterus also. Then second P is pelvic devascularizations. Okay, once you know that this is a placenta accreta syndrome, better if you are not well versed with if you have a facility of interventional radiology, then you can shift the patient into interventional radiology procedure for before taking her into section and put the intraarterial balloon catheter so that whenever needed they can be inflated and the bleeding can be controlled. Or if you are not in such setup, you have to keep everything ready for the internal iliac ligation as I shown in the previous image. And then third is no attempt to remove the placenta with en bloc. Okay. Remove the placenta, you have to see where it is adherent, and then you incise the strip of that much of myometrium itself, and then if that strip of adherent placenta, strip of myometrium goes off, then you can suture the upper and lower border, which is placenta free border of the myometrium. And while suturing, you should see that 2 centimeter margin of the myometrium is retained in the lower part of the uterine incision, so that you can close the uterus in 2 layers. Okay. And suppose the placental bit is there, which is adherent to the bladder, you leave that placental bit there only and control the bleeding by suturing. Okay, which will avoid the cystosomy. These all are the pictures of the same. Okay, then comes the other surgical management. These all are like conservative management, which definitely are surgical management only. Then the other is a radical management by postpartum hysterectomy. Don't wait much so that patient will go into the irreversible shock. Take your obstetric hysterectomy decision early if you are not able to control the bleeding by any other conservative management. So additional procedures like oversaving of the placental bed or uterine compression sutures, balloon tamponade, vessel embolization, histoscopic resections. If you have left the placental bead and it is taking too much long time, then you can go for remaining bits you can take out, histoscopic guided. Then giving a mifepristone, misoprostol to expel those placental beads. Earlier, methotrexate is again a dicey thing. HIFU is a high intensity focused ultrasound therapy to remove the remained placental beads. Then to dissolve at the site for by necrosis methods. Then resuscitative endovascular balloon occlusion of the aorta. Then this is possible where the intervention radiology is there. Then stepwise devascularization and bilateral internal iliac ligation. See, every obstetrician should be very well known for internal iliac ligations. This is life-saving procedure and I'm a very strong propagator of that. If you do internal iliac ligations, you will control the bleeding in time and then you will get a time to manage the other things also. So if you are in a teaching institute, please teach your all postgraduates when before going out of your institute, they should know the internal iliac ligation. Okay, so criteria for considering consideration of delivery in a where should be when we should intervene. Okay, for delivery when you are suspicious of morbidly laden placenta on sonograph, placenta previa with abnormal ultrasound appearance, placenta previa with more than 3 previous section deliveries, prior classical cesarean delivery and anterior placentation, prior endometrial ablation or pelvic irradiation nearby, or any ischemic procedures I told will increase this risk. Okay, so this is my last slide. I will recommend that if you find such cases where you are highly suspecting placenta accreta and placenta previas, don't see that these all facilities are available with you and then only keep the patient with you. Otherwise, refer the patients to a higher centers where multidisciplinary team is there, ICU facility is there, blood and blood products requirements will be fulfilled, because it is not like that you have started the procedure and in between only you are calling somebody or you are referring the patients in between the procedures thinking of, so definitely the result will not be good and maternal mortality will be very high in such cases. So see that you refer such patients in time for the antenatal consultation and further delivery with this all kind of team available where expectant maternal fetal medicine physician or obstetricians who are managing high risk obstetrics, imagings is there, pelvic surgeon like gynecological oncology or urogynecologists is available, not necessarily all, but who are expert in managing these all kind of things, or surgeons who are helping them, proper anesthesia team, urologists, trauma surgeons, or interventional radiology if possible. Then neonatologist, of course, is a very important person. Then ICU facility where ventilator facility is available, neonatal NICU is there. Then blood services where massive blood transfusion capacity is there. Please refer patients to such institute in time to save the patients. So my take home is incidence of placenta accreta syndrome is increasing parallel to increasing cesarean section rates. Management by multidisciplinary approach in a center with the expertise for dealing with placenta accreta syndrome can optimize the maternal and fetal outcomes. More innovations are needed since RCTs are almost impossible. Best modalities to decrease the incidence of placenta accreta syndrome would be to decrease the primary cesarean section rates. Not only that, prediction of placenta accreta syndrome and timely interventions and timely referral is also a key point in successfully management of such patients. Thank you one and all.
Thank you, Prabha ma'am, Gauri ma'am, Dr. Vishwanath sir, Savita ma'am. Any take-home messages from this talk on placenta accreta syndrome, ma'am? Dr. Patel, ma'am?
Good evening. Dr. Prabha Desai, this was very informative talk, especially this placenta accreta syndrome is one thing where it's very scary for all the obstetrician. We have covered everything from pathophysiology and including the biomarkers, importance of biomarkers, and catching the points like bleeding in the first trimester and second trimester. One should look vigorously for placenta accreta and ultrasound markers, especially with previous cesarean section. One should be very careful with previous history of myomectomy and adenomyosis removal, etc. And one thing what we all can do is we should try to prevent uterine niche. You said uterine niche is one of the reason for placenta accreta. So that like if we follow, if at all possible, whenever it is possible, of course it is not always possible whenever there's a very thinned out lower segment. The far near and near far closure of the segments, the upper and lower cut border, so that the scar integrity is maintained. We can avoid placenta accreta to a large extent because a lot of cesarean sections are happening. Such various points you have covered, madam. And how to manage, when to do hysterectomy, when not to do, all the precautions and signs you have covered very well. Thank you very much, ma'am.
Thank you, ma'am.
Dr. Savita, ma'am?
Yes, ma'am. Ma'am, Prabha, ma'am, you have done excellently good presentation, ma'am. And the slides of imaging were too good. And it was very, the clarity was very nice. And the triple P, that procedure was also very highlighting point in this presentation. Thank you so much, ma'am. It was really wonderful.
Dr. Vishwanath, sir? So please unmute yourself,
Thank you.
sir.
Yes.
Yeah.
Thank you, ma'am. Thank you. It was a wonderful presentation. And on this topic, whenever we do get scan for this previous two LSCs, previous cesarean section, better we get it. Sometimes what happens is we get referred cases from the other hospital, unknowingly we take up for the section directly. So some places, remote places, we miss placental accreta. So whenever such cases comes, we better screening we should do, and we should get it scanned again before we take up for the OT. That is my add-on to this session. Thank you so much for the it was so informative, and thank you so much.
Thank you, sir. Thank you, Prabha ma'am, and thank you, chairpersons, Patel ma'am, Vishwanath sir, and Savita ma'am for this very, very informative session on a topic which is really sends shivers down our spine. Moving on to the next session, I hand over for
Madam,
the session
shall I add
to the next
something,
coordinator.
madam?
Yes, sir. Yes, sir. Definitely.
Hello, madam. Please, I am Dr. Manoj Tansal from Bagalkot, madam. Just as madam told, for PG sake, always like they will be enthusiastic to operate all the cases. They should be very careful that such patients are there. They should do under the cover of seniors. Second thing, as madam told, like they should have like internal ligation sections and all. Third thing, when they localize the placenta, if placenta is, though it is central or covering, when it is high up anteriorly, then there is like always bladder pushing has to be done. Bladder has to be traced and it has to be pressed down, and ufold has to be pushed down as much as possible, so that provided there is no bleeding, and try to keep stay stitches. Hopefully it may bleed, I agree, but the placenta is high up, and though then you sometimes may cut through the placenta, take out the baby. That time they should not be panic. They should be very hurry while taking out the baby. Otherwise they lose the baby, because especially anterior placenta PGs, they should know when we sometimes inevitably we have to cut through the placenta, and we will both mother and baby will be at risk.
Yeah.
That need to be noticed,
yes,
because
sir.
like somebody will definitely lose a baby. Yes, madam. So
Yes, sir,
taking
your
out the
point is
placenta,
correct.
like where it is. Yes, madam.
Sir, Manoj, sir, it is applicable if there is no accreta. Okay, if no
Yes,
accreta, you can go in case of low-lying placenta or anterior placenta or placenta previous. When there is no accreta, percreta, then you can go through the placenta and take out the baby, because you are sure that there is no adherence. But when there is already percreta or increta is there, if you cut through the placenta, then it is very difficult to manage that
like
bleeding.
so many cases
So
we
that's
operate
why this
maybe.
triple P also you should know. That's why in triple P also they said that prior to taking for prenatally only you should know where is the upper border of the
Yes, yes, ma'am.
placenta.
But sometimes
Definitely,
very
if it is not
rarely,
anterior,
like
then
we
there
have
is
come
no
across,
question.
like sometimes we don't have space to put incision, though you go high up also.
Yeah,
no?
yeah, yeah.
That's why I told
Yeah,
like
yeah.
1 in 10 cases we expect in placenta accreta, 1 in 10 cases of them, at least sometimes you have to cut through the placenta because the
Yeah.
patient will be under GI.
If it is
Sometimes they
posterior, then
and
is no doubt
yes,
only.
yes. Posterior, no problem at all,
Yeah,
not at
yeah.
all. The
Only
that's
adherent,
cakewalk.
but anterior, if you go through the
Anterior,
placenta, then only it is a major issue actually.
yes, yes, ma'am. Because sometimes while doing no, the placenta will be thinned out very soft and all, then they extend into the bladder also.
Yeah,
So
yeah.
we may open the bladder also so many times. So if they push down the bladder, it's gone down slowly, nicely. They should be very happy. At last, they can immediately they would hysterectomy. If bladder
Yeah,
is
yeah,
not
yeah.
going
Of
down,
course.
they should not put incision on the uterus till they get some seniors.
Yeah, yeah.
Because no, once
That's
you
why.
put the incision on the uterus, the battle started. Before your senior comes, you must have lost the patient also or baby also. So if bladder is not getting pushed down, don't put incision. Wait for your seniors, I feel. Like postgraduate, like experts are they're doing, I know, no? Just for it's my experience, I wanted to share
Yes,
it.
yes. No,
Yes,
these
madam.
all cases
Otherwise, it
are
was
not
wonderful,
for
no?
postgraduates, sir. Always it is for
No, they
doctors
also
only.
joined. No, they would
Yeah.
have joined.
Yeah,
So
yeah.
some PGs will be joining, no? So we
No,
keep teaching them.
Yeah.
We all are professors now. We will keep teaching our PGs like
Correct,
when to push the bladder. Sometimes like we tell them you put incision high up. No, they will never open up. They will never see the
Oh.
fluid is openable or not.
Correct,
That is
correct.
very best now because we have already directly told them we put incision above the placenta. They never think of seeing whether the
Oh.
UV fluid is freely separable or not. If it is not
Yes,
freely
yes.
separable and you see the huge vessels or it is very thinned out means wait for your senior professors because definitely instead of one hand, two hands are always safe to save
Thank
the
you.
patient.
Thank you. Thank
Yes,
you,
ma'am.
Prabha ma'am.
Thank
And
you,
thank
madam.
you,
It was very
So,
nice.
Manohar
like I
sir, for
just asked, this is
Yes.
one YouTube video I put for your PGs. You can recommend them.
Yes,
This
ma'am, definitely.
how to push the bladder in such cases. Yes. Thank you, sir.
Yes, madam.
Thank you,
Thank you, madam. Thank you so much. It was
Monica
very
madam,
wonderful.
and thank you, Patel sir.
Thank you. Thank you.
I'll
I now
stop
hand over.
sharing. I'm stopping sharing.
Yes,
Yes,
welcome.
thank you, ma'am. Thank you, ma'am. And we're now moving on after a lot of practical and theoretical knowledge of placenta accreta as well as massive transfusion protocols. We move on to the next session, third session on medical legal aspects. And I hand over to the coordinator for the third session. Dr. Monica.
Nivedita, anybody can do, no issue.
Okay, fine. And this session, obviously, to have the medical for a session on medical legal on any subject, the expert, none other than Dr. MC Patel, sir, a person who is by the people, for the people, of the people, as well as the medical legal expert. To chair the session, we have Professor Dr. Could we have this thing? Professor Dr. Vardap, Dr. Sarita. Please go ahead, please. Dr. Sarita Badbade, she's a professor of Obs and Gynae, Maheshwara Medical College, President IMA Women's Doctors Wing Vidar, the past president Vidar Obs and Gynae Society, and she is a trainer of trainers for PPIUCD, skilled birth attendant, and CAC service provider for subdermal implants, Implanon. The next chairperson for the same session, the next please. Professor Dr. Meenal Holkar Vardhan. She's again a medical teacher, guide, evaluator of Vidar Institute of Medical Sciences, examiner for undergraduate and postgraduate students, district trainer for EMOC, PPIUCD, and Implanon, and active member of POXI. Next, the third chairperson for the series, Dr. Manohar Tankasali. We've just heard him speak also, and his knowledge was evident. He is presently the secretary of Bagalkot Obs Society, presently working as director of Bagalkot Multi-Speciality Hospital, associate professor in SN Medical College, a PG guide and examiner for many years, a lot of publications of national and international journals, and special interest in PPH, Obstetric Emergencies, Lap and Fertility. I'm sorry, sir, if I got the surname wrong. It's really my apologies for the same.
No,
I would
no problem, no problem. Spelling. Thank you so much.
I request any of the chairpersons to please introduce our eminent medical legal expert for this session. Dr. Manohar, sir, if you would do the honors.
Yes, madam.
Introducing Dr.
Second,
MC Patel, sir. Or do you want that me to do this?
Yeah.
Yeah, please,
I
can
will
you
do
go ahead,
it.
madam? Because I am on the
Fine,
please,
fine, fine. Yeah.
Okay, I'll do
Yes.
it. Good evening,
Yes,
everybody.
ma'am. Please, madam.
First of all, thanks very much for conducting this webinar. We have had the pleasure of hosting Dr. MC Patel in Bidar. He's a keen academician and he was very much concerned about the medical legal aspects, and he was very kind enough to come to our Bidar Obs Gynae Society, and now this webinar for 5 societies across Karnataka. So, and as we have heard in the introduction, he is always ready to help. So that is what I feel he has professional leadership as president of AOGS. He is a president of IMA Ahmedabad, national president of NMO, organizing chairperson of the Vivekanand NMO.com, and he's a community and service. He's an honorary surgeon, Red Cross Eye Bank, collected 1,000 eye pairs services in medical camps in Northeast states under Dhanvantari. Seva Yatra under NMO and Seva Bharati organized since 23 years. Services in medical camps in Jammu and Kashmir under Dhanvantari Seva Yatra. President of the Lions Club, Ghat Lodhia. And, highlights about him: Foxy uniform consent. He was instrumental and he played an instrumental and pivotal role. Medical legal training and support for members. That is his expertise, and which he is very keen to distribute to the members. He was vice president of Foxy in 2018, chairperson Ethics and Medical Legal Committee. He is the organizing secretary for AICOG, honorary secretary, State Organization of Gynecologists and Obstetricians of Gujarat. He was the organizing chairperson of MMCOM, honorary member of Foxy, PNDT, Violence Against Doctor and His government and statutory roles include the PNDT and IMC Government of India. He was part of the Gujarat PNDT State Supervisory Board. He is in the National Medical Managing Body, Indian Red Cross. So,
Thank you.
presenting Dr. MC Patel.
Yes. Thank you, madam, for kind word. And
Sir.
let me share my screen.
Yes, sir.
So, is my screen seen?
Yes,
Is
sir.
it seen full screen?
Yes, sir, we can see.
Is it full screen? Hello. Is it seen full screen?
Yes, sir. No, we can
It's not in
see.
slideshow. It's not in slideshow, sir.
In my computer, it is in full screen. No issue. Let me do again.
Hello, Deepa, by mistake ಬಂತು. ಅರೆ
It's not getting. Host, have you allowed me to share, because I am not getting all this.
Yes, sir. Your screen is visible.
Then, but
Yes, sir, your screen is visible, but not in the slide share mode.
it is not getting open just now. I don't think why getting open.
सर अपना वीडियो ऑफ करके देखिए, हो सकता है नेटवर्क का इश्यू हो सर।
ना नेटवर्क, चलो ये भी कर लेते हैं, लेकिन होना तो नहीं चाहिए ऐसा।
अब फिर से स्लाइड शेयर शुरू कीजिए सर।
वही कर रहा हूँ। ये शेयर हो ही नहीं रहा, पता नहीं व्हाई इट इज हैपनिंग दिस।
नहीं सर, शेयर्ड है, स्लाइड मूव नहीं कर रहा है, शेयर्ड है।
ये मानो कि मैं स्लाइड पर क्लिक कर रहा हूँ, तो ये
तो आगे नहीं बढ़ रहा है।
ये नहीं हो रहा है।
स्टॉप शेयर सर।
Let me stop sharing.
Yeah, stop share and start again.
And start resharing and reshare again. Yeah.
That it may work. Is it seen?
That was mine.
Yes, sir.
Nothing to feel guilty about. You're back at Fruit Corporation. Time to pay the balance.
Now
Right.
full.
Less.
It's again in the. No, sir.
So in my computer, it is in full screen. And why?
Sir, no issues, sir. You keep scrolling down.
Doesn't
make a difference even in
it
this.
will be difficult for me. So it is. Let me try one again.
Thank you.
Okay, share screen. Now is it seen full screen? Hello, is it full?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Full
Yes,
screen?
sir. Yeah.
Full
Yes,
screen.
sir.
Okay, fine.
Now you scroll, sir.
No, then it's fine. So greetings from Statue of Unity,
Yes, sir.
tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all the president and secretary of respective society, and Dr. Deshmukh Madam and Dr. Vinayak in particular for helping for this webinar particularly. I also thank you all supporting during my candidature for President Foxy last time, though I lost. But I believe in this. This is very nicely written by Shraddhay Atal Bihari Vajpayee. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end but a new beginning, and journey to serve Foxy continued with renewed patience. And my commitment is still there. Wherever you are, I'll be there. Promise to reach the unreached. So I'll be seeking your blessings for the same post, President Foxy. This year, election year 2026. Election would be from 1st August to 10 August. But before that, in month of April, most probably last week or first week of May, all the president and secretary of respective society will get communication from Foxy for nomination. And this time it is e-nomination. So it is a job of only less than 1 minute to nominate my candidature for post of President Foxy. So first you will nominate my candidature for your society, and then in election days, you will vote and make others also to vote for me. Usually I start any of my talk with this question. Is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. As far as any litigation area you select, whether it is CPA, whether it is civil suit, whether it is criminal one, or in NMC, or in government, or in Human Rights Commission also, whichever area patient and patient party prefers, but gynecologists are in driving seat as far as number of litigations are concerned. We take utmost care of any of our patients in our obstetric practice, but we never know. Accident may happen. And once accident happens, it becomes a potential area as far as litigation is concerned. And our situation is like this. We have to save mother, we have to save baby, and at the same time, we have to save our own cap, and that is our obstetric practice. So let us see, these are the real happen cases and decided in different courts. And this is a very real happen case which was decided in Supreme Court. It was a case of lower segment cesarean section. There was atonic PPH after cesarean section delivery. Uterotonics were given. In spite of applying sutures, bleeding was not getting controlled, and it was 3+. So informed consent was taken and subtotal hysterectomy was performed. Blood and its components transfused to correct hypovolemic shock, and case was filed in this particular case. So argument was on part of doctor was, it was life-saving emergency. This subtotal hysterectomy was the point in issue, that why hysterectomy was done. Pursued standard medical textbook, SOS textbook and Williams textbook, and from those textbook references were given, and court has considered those references. So inference held by the court was, postpartum hemorrhage is well known. It is dreaded and leading cause of maternal morbidity and mortality worldwide, even in the best centers. Process of childbirth can take a lethal turn, and only qualified obstetrician can understand uterine atony after childbirth as the most common cause, and it can lead to rapid and severe hemorrhage, shock, DIC, multiple organ failure, and ultimately death. And in few studies, the most common indication of emergency obstetric hysterectomy was uterine atony, almost in 25% of the cases, followed by morbidly adherent placenta in 21%, and uterine rupture in 71%. But uterine atony is the main cause as far as hemorrhage is concerned, and this reflects the situation in most developing countries, where atony accounts for a majority of cases of emergency obstetric hysterectomy, but also shows a rising curve. So one more inference held by the court was, if all attempts at arresting bleeding have failed, subtotal or total hysterectomy is attempted as a last resort and life-saving measures. And decision to perform hysterectomy, although devastating for patient, should not be delayed in case of hemodynamically instability. So in this particular case was dismissed in favor of doctor, and doctor was saved from all the allegation in this particular case. But how he could win in this particular case? Because he had produced all the document of treatment given during PPH and standard textbook references from Shaw and Williams, and court has considered all those and decision was in favor of doctor. So which are the areas for litigations in this type of situation? Most common allegation in this type of situation, delayed in diagnosis, investigation and treatment. If it is a case of PPH and if it is delayed in diagnosis and management, then it could be one reason for litigation. Missed diagnosis, investigation or treatment in any antenatal hemorrhage or peripartum or postpartum, then it becomes a case of litigation. Wrong diagnosis is also one more reason. Unnecessary investigation, because when we are dealing with any obstetric hemorrhage, say for example placenta previa or adherent placenta, then naturally we have to go for serial investigation, and many a time it could be expensive, and nowadays it has become one more allegation that unnecessary investigation. No proper consent taken is one more allegation. Staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer. If at all we have to transfer patient to higher center in any case of obstetric hemorrhage, then, and if it is delayed, undue delayed, I would say, because there could be some reason for delay, but if it is undue delay, then it could be one more allegation nowadays in this type of cases. Complications related this obstetric hemorrhage and complication of management just mentioned by one of the speaker as far as massive hemorrhage is concerned, and complication of massive hemorrhage is also taken into consideration in this type of situation. Morbidity maternal and or fetal, mortality maternal and or fetal is also one more cause. Overcharging, because this type of situation naturally becomes expensive at the end of day, and this is also one more reason, and this is very common allegation nowadays. Tremendous expense against unexpected result. And if patient has asked for record and records are not provided, then this is also one more allegation in this type of situation. And failure of patient to keep up scheduled follow-up, this is also one more area. Many a time patient doesn't follow your instruction, patient doesn't come for regular scheduled follow-up. But in this situation, if we can prove that there was not compliance on part of patient, it becomes a good defense in our favor, because it becomes contributory negligence on part of patient, and it is a good defense if we can prove in court of law. So which are the areas in this type of litigation? A very common allegation, not anticipated and not prepared to manage. Say for example, if it is a case of central placenta previa, naturally one should anticipate that she may end up into PPH, she may require blood transfusion, she may require obstetric hysterectomy also. And if it is not anticipated, if one is not mentally or physically prepared to deal with the situation, then it becomes a difficult.
So you're not audible and your slides are not moving, sir. No, sir, you're not audible, sir. And this is your first slide and it's not on screen share. ये तो दिख रहा है not anticipated, not prepared to manage, but full screen पे नहीं है, sir. Corona people, can you share sir's PPTs? Then sir can even log in from the mobile.
Yeah, sure.
Yeah, thank you, thank you.
Hello. Am I audible?
Yes,
Yes,
sir.
sir,
Yes,
you're
sir,
audible.
you're audible.
Yes. And slide is seen?
Yes, sir.
Full screen?
No, sir.
Not full screen?
No, sir.
Then again I will have to do all this jugglery. No issue.
Sir, आप slides इनको भेज दीजिए सर कोरोना
नहीं
वालों
नहीं
को
नहीं
भेज
नहीं
दीजिए.
नहीं 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 ये नहीं मुझे ही करना अच्छा रहता है. नहीं, I am coming to that. No issue. Now is it seen full screen? Hello.
Yes, sir.
Yes, sir. Yes,
Yes,
sir.
fine.
Okay.
So
Thank you, sir.
we were here. When it is not anticipated, I just discussed. So very important question is asked in court of law. Was it preventable? Whatever happened, say example, it ended into PPH and it ended into hysterectomy. Then very important question is asked, was it preventable? And usually we cannot say no. So if it is yes, then what did you do to prevent it? Is one more issue we have to face. And many a time, if we cannot prevent, then this question will be asked, why you couldn't prevent it? And did you diagnose that complication well in time? Say, for example, if it is a central placenta previa and severe PPH or severe bleeding during delivery, then did you diagnose that abnormal bleeding? And very important question, did you manage way in which any prudent doctor would have managed? So we should be able to answer all those questions, then only you could be out of problem. Delayed in diagnosis, then again the same set of questions you will have to face in court of law. Reoccurrence, we know in case of placenta previa, reoccurrence of episode of bleeding are very much known, and in this situation we have to answer those also, because very common allegation is no proper care taken to avoid reoccurrence. And again same set of question we will have to face. One more area, this is our observation, that in 80% of the medical legal cases against gynecologists are obstetric related, and out of those 80% cases are related to lower segment cesarean complication, and out of those 80% of complications are related to hemorrhage. So if one wants to be 80% free of litigation, take care of bleeding, that is hemorrhage, and cross-match blood well in advance. Because in this case, let us see, this is real happened case in city of Ahmedabad only. It was case of cesarean section again. So as such, this patient was admitted in the hospital. Patient was RH negative. So she was advised that she should be for elective cesarean section with all preparation of blood. But patient absconded from hospital and reappeared in hospital 4 days after at middle of night in acute emergency. Doctor had no time to manage for blood and straightway she went with cesarean section. But unlucky that patient and doctor too, there was bilateral uterine artery tear, patient was RH negative, blood was not ready, cross match was not done. So during shifting patient to nearby Municipal Medical College Hospital, patient expired on the way, notice was served, case was filed, and allegation was not anticipated complication, procedure, and intensive care. So in this particular case, inference held by the court was in postmortem examination finding, it was mentioned that intra-abdominal hemorrhage following negligent surgical procedure, no blood kept ready, and one more area, medical record not to be believed. Because in this particular case, note of gynecologist and note of anesthesiologist were contradictory. Because in note of gynecology, she had mentioned that vitals were within a normal limit, and at the same time in note of anesthesiologist, it was mentioned that vitals were compromised. So there was contradiction. So record was not taken into consideration. And in this case, compensation of 2.35 lakhs was awarded in favor of relative. So common reason for allegation in this type of situation is not cross-matching blood during high-risk pregnancy like RH negative patient. So what is carry home message with this type of situation? Would you advocate prior cross-matching? Many of friends have habit to send a sample to nearby blood bank irrespective of mode of delivery, normal, instrumental, or operative. But on admission only, they send sample in nearby blood bank, keep at least 2 to 3 units of PCV ready, and if it is needed, then only they demand, but blood is ready in nearby blood bank. So it is abundant caution. It is not compulsory to do in each and every patient, but if at all one is doing, then it shows his concern to save life of patient in given situation. But patient is RH negative, then you have to send sample in nearby blood bank and to keep blood ready. So in this situation, just I mentioned, and consent for blood transfusion. If blood transfusion is planned prior, then separate consent for blood transfusion is very much required, because in one of the cases, court was very clear that surgery involves risk and blood transfusion involved as additional risk. So separate consent for blood transfusion is required. So this was the inference. And proper record keeping, of course, it is always at our rescue. So as far as obstetric hemorrhages are concerned, they are like 9/11, and many a time it is very late. Sometimes we diagnose the thing, and one cannot be smarter like this in every situation. And all of us know after the ship is sunk, everybody knows how it could have been saved. So we should be very careful, because every case of obstetric hemorrhage is potential threat, and treating serious patient could be suicide as far as litigation area is concerned. And we are bombarded with so many questions. One, something goes wrong as far as obstetric hemorrhage is concerned. Who is responsible for this? Where were you? Why you couldn't prevent it? How this happened? Why you didn't manage case efficiently? So there are so many allegations on part of patient and patient party in this type of situation. So what to do and how to prevent? You have to do only three things. That is
ಇಲ್ಲ ಅದನ್ನ ರೊಟೇಟ್
foreseeability,
ಮಾಡೋ ಡೌನ್ಲೋಡ್ ಮಾಡಿ
anticipation.
ಇಲ್ಲ ಅದು ಇದು ಮಾಡೋ
There
ಅದನ್ನ
is,
ಇದು
there
ಮಾಡೋ
is somebody
ಡೌನ್ಲೋಡ್ ಮಾಡ್ಯಾ
mic is on. So host, please unmute them. So practice foreseeability, that is anticipation. It is expected from court and law also. Good communication and proper consent and documentation. So as far as anticipation is concerned, just I mentioned prior also, one should anticipate complication, procedure and intensive care. Say for example, if you are dealing with a adherent placenta spectrum, so we have to anticipate that she may end up into PPH, she may require blood, she may require hysterectomy also. So in this situation, we should be prepared to deal with the situation accordingly. And in this situation, very important part is when one should be vigilant or anticipate PPH in certain condition, as far particularly atonic PPH is concerned. Multiple pregnancy, naturally one should anticipate grand multipara, large baby over 4 kg of weight, anemia, polyhydramnios, prolonged labor, placenta previa, placental abruption, retained placenta, remnant of placental tissue, retained amniotic fluid, amniotic membrane, blood clots, mismatched third stage of labor, and full bladder. So whenever these are the situation, we should anticipate that she may end up into a atonic PPH, and we should be readily available to deal with the situation. And we have to try to overcome all this situation. One more area in this type of situation, would you like to involve other colleague whenever you are facing this type of emergency, or would you like to treat alone? Naturally, we have to involve our professional colleague, and preferably since beginning. And our approach should not be like this, I am the only consultant, because balanced teamwork is always beneficial, not to the patient only, but to the doctors also. But in all this situation, proper counseling and consent is very much must. Why I have mentioned word proper? Because in one of the cases of C. Jaipal Reddy versus Padmini Velluri, National Commission has mentioned that case, this consent is not mere case paper where patient or patient party has to sign, but it is a very important document of your counseling, of your communication. So whatever you counsel, whatever you communicate, it should be entered in consent paper, and then patient has to sign, and then only it becomes a proper counseling and proper consent. Would you give guarantee in this type of situation whenever you are dealing with adherent placenta spectrum or placenta previa or abruptio? Because in our practice, no rosy picture about result, no tall claim. Because in eye of law, when you claim to be master, then you are supposed to be master. And in our obstetric practice, particularly in obstetric hemorrhage situation, we consider our result like Aishwarya Rai, but it may turn like this at any time. So no rosy picture, no tall claim, and records are always at our rescue. So whatever we have done to save life of that very patient, to save her uterus, is always taken into consideration, and we can prove it by proper records only. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. Important bills are also part of your record. Say, for example, purchase of oxygen cylinder, and not only purchase, but refilling of oxygen cylinder bill is also part of your record. Purchase of defibrillator, ventilator, emergency instrument like ambu bag, all emergency drugs. So we should have bill of all this. And as far as refilling of oxygen cylinder is concerned, in this particular case, allegation on part of patient party was when patient suffered a heart attack, oxygen cylinder in hospital were empty, and we were saved in this particular case only due to producing bill of refilling of oxygen cylinder just one day prior. So though it is a very simple thing, but it is a very important document in your favor. It shows that you are taking utmost care to manage patient in any given situation. Transfer of patient, whenever you have to transfer patient, it should be in time at proper hospital, and you will have to confirm about bed, ventilator, OT, and availability of blood also, because many a time it may happen that patient reaches that very hospital, ventilatory support is required, and ventilator is not available. Patient will have to be shifted to another hospital, and precious time is wasted. So confirm availability with right and proper person about all this. escort patient in the same ambulance is very much must. Handing over patient to right and proper person and mention date and time of handing over. At the same time, you will mention date and time of transferring patient to another hospital, and you have to give all the transfer document to the patient. But before that, nicely mentioned by previous speaker also, pneumatic anti-shock garment is very useful kit, and it shows your consent also. Of course, it give you time to treat that very patient, but whenever you are shifting patient to higher center, then it is very much must, and it is good defense in your favor. As far as transfer document is concerned, this is a list how you have to give all those transfer document, and this is checklist. I do not want to go into detail, but before that, I would say that preserve all the transfer note given to the patient and patient party. One copy should be with you, and you have to simply Foxy website under this title of Foxy Uniform Consent. 30 different consent are available. Three medical legal expert, Dr. Dilip Palke from Pune, Dr. Nikhil Datar from Mumbai, and myself, MC Patel from Ahmedabad. We have prepared 30 different consent, and in those very consent, how to transfer patient is already given. You have to simply download and you can use in your day-to-day practice. So to conclude, there is always a way. So we have to treat our patient with all these carry home messages. Antenatal and labor ward protocol we have to strictly follow. Adequate supervision and monitoring, proper communication, counseling and consent, proper documentation and record keeping, foreseeability and anticipation, in-time transfer, multi-speciality approach, medical audit of our own case, so not to end up into same problem in future in another patient. And in era of CPA, one cannot afford practice until you are well covered with indemnity cover. As far as this realization is concerned, medicine is a science of uncertainty and art of probability. So very nicely mentioned by this fellow also. The problem with world is that the intelligent people are full of doubts while stupid ones are full of confidence. So we have to decide where we stand and remain alert every time. Otherwise, be ready to face this type of situation, because this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many judgments in Supreme Court and in different high courts in our favor, in favor of medical fraternity. But if you do not know, if we do not use those judgments in our favor, if we do not use our standard medical textbooks references, then they won't be useful in our favor. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So if you want to sleep like this, take tender care of your patient, pray Almighty God before going to sleep, and keep my visiting card below your pillow, because I am always there to assist you in any odd given situation. So all the best, God bless you, and have a medical litigation free practice. With regards, and before I conclude, please endorse my candidature for post of President Foxy election year 2026. Salute to all. Thank you. Thank you very much. Please do not assume. Please ask if any question, if any query, if time and chairpersons permit. Thank you. Thank you very much.
Thank you, sir.
Thank you, sir. It was very
I can see
wonderful
Manohar,
presentation.
sir. One of you.
Yeah, please. Hello, madam. Hello.
Yes, Manohar.
Hello.
Please, sir.
Yes, sir.
sir.
Thank you, sir. It was very wonderful presentation, and you had been to Bagalkot. We were very happy that day. You gave a lot of put a lot of light on the medical legal issues. We witnessed your talk, and all. We were very happy, sir. Last year you came to Bagalkot. Thank you very much, sir.
Yes.
Any audience have any questions? That will be available. Sir, we used to take home message. Thank you so much. Yeah. I think there are no questions, sir. You covered everything.
Fine.
So it was nice, sir.
So,
Sir, thank you.
with your concluding remark, we can close this session and switch over
Yes,
to
sir.
further next session.
Thank you very much, sir. Thanks.
Okay, thank you. Thank you. Yes, Satabdi, over to you.
Yes, sir. Thank you. Thank you so much, sir. One more, I can say, gamut of knowledge from you. We will move on to the panel discussion. We have a panel discussion on a very, very, very important topic today. That's management of postpartum hemorrhage. We have Dr. Avinash Patil, sir, and Dr. Vinayak, sir, as the moderators, and Uma, madam, as the expert panelist. So, Dr. Avinash, sir, is a fertility consultant at Patil's Life Care Hospital at Devangiri. He has a special interest in hysteroscopy and laparoscopy and fertility enhancing surgeries. Welcome, sir. Dr. Vinayak
you,
is a
madam.
consultant obstetrician. Yeah, welcome, sir. Is a consultant at Bidar Institute of Medical Sciences and a medical teacher, FMAS PG Diploma in Medico-Legal Ethics, and an active member of FOXI. Welcome, Dr. Vinayak. Next, we have our expert panelist, Dr. Uma Deshmukh, ma'am. Dr. Uma, ma'am, is an advisory committee member of PCPNDT for Bidar district. She also has been the nodal officer for maternal mortality of Bidar district and has been the IMA vice president and president of the Bidar Obs-Gynae Society. Welcome, ma'am. We have 7 panelists with us today. Firstly, we have Dr. Pranita Ajay, ma'am. Dr. Pranita is the past VP of the Belleru Obs-Gynae Society, as well as a consultant at SK Pandurang Rao Multi-Speciality Manyata Recognized Hospital at Ballari, and has been practicing for the past 25 years. Welcome, ma'am. Next, we have with us Dr. Purnima, ma'am. Dr. Purnima is the senior gynecologist at Ballari. She is associated with the Gunashila IVF Center at Bangalore and Rangadore Memorial Hospital at Bangalore. Welcome, ma'am. Next, we have with us Dr. Shobha, ma'am.
Thank you.
Dr. Shobha, ma'am, is a consultant at Ilkal Bagalkot, also the secretary of the Bagalkot Obs-Gynae Society, and has been the past secretary of the Critical Care Committee of Kasoga and chairperson of the Safe Motherhood Committee of Karnataka. Welcome, ma'am. Next, we have with us Dr. Kalavati Biradar, ma'am. Ma'am is a professor at MIMS, has been MIMS at Vikarabad from September 2024, and also has a special interest in infertility and high-risk pregnancy. Welcome, Dr. Kalavati. Next, we have Dr. Nagaratna Gaurkal, ma'am. Ma'am is a professor of OBGY at SN Medical College, Bagalkot, and also is the ex-president of the Bagalkot Obs-Gynae Society. Welcome, ma'am. Next, we have with us Dr. Aarti Raghu, ma'am. Ma'am has been the vice president of IMA Bidar, is the member of Perinatology Committee of FOXI and advisory committee of District PCPNDT Bidar. Welcome, ma'am. Last but not the least, we have with us Dr. Shruti Bhavi Patil. Dr. Shruti is an associate professor and unit head at GIMS at Gadag, Karnataka. She also is the MEU coordinator from Gadag, as well as the executive committee member of Northwest Zone Kasoga, and has been the president of the IMA Women's Wing of Gadag. Welcome, Dr. Shruti. Over to you, sirs. Looking forward to a good panel discussion.
Thank you, madam. I request Dr. Vinayak to just brief about the postpartum hemorrhage.
Yes, sir. I will
Before
be
we
sharing
move
the
on to
slides.
panel discussion.
Everyone can see the slides?
Yeah.
Yes, Dr. Vinayak.
You can go ahead, Vinayak, doctor.
Yeah, good evening, everyone. It's a great privilege to be among the stalwarts of obstetrics and gynecology. So, coming to the postpartum hemorrhage, in spite of recent advances in obstetrics and gynecology, PPH remains the leading cause of maternal mortality. So, according to FIGO, postpartum hemorrhage or PPH is a blood loss after the baby is born that's more than or equals to 500 ml in vaginal delivery or more than or equals to 1000 ml in cesarean section, or any blood loss causing hemodynamic instability. In practice, clinically significant bleeding matters more than the volume. So every day, approximately 830 women die from complications of pregnancy and childbirth. PPH is a major cause and majority of these deaths are preventable. So if you look at the data, so 24% of the maternal deaths are due to PPH. And if you take the states like Madhya Pradesh, UP and Assam, this goes till 34 to 50%. So according to ACOG, the definition is cumulative blood loss of around more than equals to 1000 ml or blood loss associated with signs or symptoms of hypovolemia. within 24 hours of the birth process. So recent guidance by FIGO and WHO, that is in 25 and 26, they have updated the definition of PPH. Early clinical trigger, that is a blood loss of more than or equals to 300 ml plus abnormal vitals, that is pulse more than or equals to 100 beats per minute, shock index of more than or equals to 1, systolic blood pressure of less than 100, and diastolic blood pressure of less than 60 millimeter of mercury. The diagnostic definition is objectively measured blood loss of more than or equals to 500 ml. And coming to the key updates are, it is shifted from wait and watch to recognize and act early. That is at 300 ml of blood loss, early intervention threshold, and 500 ml is a diagnostic PPH. There is a motive bundle given by the WHO and FIGO. M counts for the massaging the uterus. O for oxytocin, that is like oxytocin or carbetocin. Previously, carbetocin was only used for the prevention, that is prophylactic for the PPH, but now they're advocating in the treatment also. Then T for tranexamic acid, that is 1 gram IV within 3 hours. I for IV fluids, and VE for volume assessment, plus SLA. So these are the different definitions by the different bodies, like ACAG says 500 ml for vaginal delivery, 1000 for cesarean delivery. And there is one term from ACAG, that is severe PPH, which is called as 2000 to 2500 ml of blood loss after delivery. So blood loss of more than 40% of body weight is life-threatening. So if you consider a normal average Indian pregnant woman, if she is weighing around 60 kgs, so around 2400 ml of blood loss is life-threatening. Dr. Hadisa from Bayero University says, you never forget the experience when a woman just slips away in your hands due to PPH. Women die from postpartum hemorrhage because they don't receive early, effective, and aggressive life-saving treatment. There are mainly 4 types of delay in PPH. The first delay is delay in deciding to seek medical help for obstetric emergency. The second delay is delay in reaching appropriate health facility once the decision has been made. And third delay is delay in receiving appropriate care once the facility is reached. And the fourth delay is timely referral. These are the words of wisdom from Sir Ian Donald. While managing PPH, time lapse should not be counted in a minute. One has not lost 1 minute, but 60 seconds. So time is very precious in PPH. Uterine blood flow at term is around 700 to 800 ml per minute. Uterus can simply pour blood and lead to death within minutes. So the golden hour usually was advocated in sepsis, but now it is advocated in PPH also. First 60 minutes from the recognition of PPH to which resuscitation must begin to achieve maximum survival. As more time elapses from the time of PPH to resuscitation, the percentage of survival of patient decreases due to metabolic acidosis. The assessment can be made from the shock index, that is obstetric shock index, which is heart rate by systolic blood pressure. Normal is around 0.5 to 0.7. Then modified shock index, which is heart rate by mean arterial pressure, which is normally is less than 1.3. The most important rule in massive obstetric hemorrhage is rule of 30. When there is massive obstetric hemorrhage, the systolic blood pressure falls by 30 millimeter of mercury, pulse increases by 30 beats per minute, hemoglobin drops by 30%, that is approximately 3 gram per deciliter, hematocrit falls by 30%, and estimated blood loss is around 30% of the normal. These are the different grades of shock, that is class 1 is less than 1000 ml of blood loss, class 4 is more than 2000 ml of blood loss. So now coming to the cases for panel discussion. So case number 1. So over to Dr. Avinash sir for the discussion.
Thank you, Dr. Vinayak, for that elaborative talk on PPH management and all. Let's move on to the case. This is case number 1. She is a 36-year-old Gravida 5 Para 4 Living 4, 38 weeks of pregnancy. She is known case of GDM and treated anemia in pregnancy. She is on insulin and she has been induced at 38 completed weeks for GDM. She delivered a healthy baby, 3.8 kg, and active management of third stage labor was done. But patient suddenly started bleeding profusely after the removal of the placenta, and placenta was complete. Pulse rate is 80 beats per minute, BP is 110 by 80 millimeters of mercury, and estimated blood loss is around 800 ml. My first question is, what do you think the cause could be? Dr. Purnima,
Yes.
madam, are you there?
Yeah, I am there. So
Yes,
first
ma'am.
of all,
Can
I
you just
thank
tell
Ballari.
what could be the cause?
Yeah. So here the cause, most likely cause is atonic PPH, as there are multiple risk factors such as she's a grand multi and large for gestation age, GDM, and also she has associated anemia, and she's been induced for the labor. So these are the risk factors that could be the atonic PPH being the most common is the risk factor cause.
Okay.
So, yeah.
Can you just tell me how can you minimize the anemia in pregnancy?
So antenatal detection of anemia is very important, and treatment. So antenatal anemia
Okay.
should be investigated and treated appropriately, as they may reduce the morbidity associated with the PPH.
Okay. Thank you, ma'am. My next question is, what type of PPH is this and how will you manage? Dr. Shobha, ma'am, are you there? Dr. Shobha, ma'am, you can just unmute yourself. Dr. Shobha, are you there?
Anybody else can take the question if Dr. Shobha is maybe with some work if she is not available.
Dr. Vinayak, I think if Shobha ma'am is not there, you can just take this question.
So
What
mainly,
type of PPH is this and how will you manage?
mainly it is a mainly atonic PPH. Like when you come to the 4 T's of the PPH, one is tone, trauma, and thrombin and the tissue. And in this patient, if you consider the GDM, multigravida, macrosomia, induction of labor, and anemia, all goes to the atony of the uterus. So the cause can be atony of the uterus. Minor intravenous. What treatment you have to do is for if there is minor PPH, it is around 500 to 1000 ml of blood loss, and we have to take the intravenous excess, that is 1 to 14 per cannula, 2 cannulas, urgent venopuncture, group and screening for the blood group, full blood count, coagulation screen, and including the fibrinogen, pulse and respiratory rate, and including the blood pressure recording every 15 minutes. So coming to the, once we come to the medical management, it includes uterine massage. We have to empty the bladder along with oxytocin of 5 international unit, usually 20 international unit, slow IV if 5 international we can give 5 international units slowly IV. Then we can go for methyl ergometrin 0.2 mg slow IV or IM, oxytocin infusion, that is 40 international unit in 500 ml of NS. And if there is no response, if the blood loss is continued, the pallor is increased if the uterus is flabby. So in this case scenario, like if the pulse is 86 and the blood loss is continued and approximately 1000 ml, so what next? So next we can move up the protocol. We can do carbopush like 0.25 mg IM every 15 minutes up to 8 times. Then we can give carbopush intramyometrial also if you are in cesarean section. Then misoprostol 800 micrograms sublingually you can give. Then consider tranexamic acid 1 gram IV.
Okay, thank you, Vinayak. As you mentioned, lastly, is there any role of tranexamic acid and how it will act? Dr. Aarti, are you there? Take this question.
Yes, sir, I'm there. Actually, my first line of treatment always in any bleeding is tranexamic acid, sir.
Okay.
With any cause, even before establishing cause, if somebody is bleeding, I give tranexamic acid, and usually I give 1 gram. It is available in 10 ml. I give slow IV over 5 to 10 minutes. And if the bleeding stops, it's okay with other uterotonics and all. If after 30 minutes also bleeding persists, then I repeat the dose of 1 gram again. And if the bleeding doesn't recur till 24 hours, then I don't give the repeat dose. Tranexamic acid is very important. And nowadays we are giving, if the lady is high risk for PPH, that case is in during cesarean section also we are giving prophylactically, not 1 gram, but 500 mgs.
Okay, thank you, madam. Thank you. I'll just summarize. Tranexamic acid 1 gram IV. The dose is at 1 ml per minute. And second dose of 1 gram IV if the bleeding continues after 30 minutes or if the bleeding starts within 24 hours of completing the first dose. So definitely tranexamic acid reduces the maternity mortality due to PPH by 30%. Thank you, madam.
ಇಷ್ಟು ಬೇಗ ಬಂದಲ್ಲ ಇಷ್ಟು ಬೇಗ ಬಂದಲ್ಲ
Question 4. What are the prerequisites for balloonate tamponade? Dr. Nagratna, ma'am, are you there? Can you take this question?
Hello.
Dr. Nagratna, ma'am.
Yeah, hello, sir. Thank you, sir.
Yeah, ma'am.
Yeah. Before I go into that, whenever there's any case of PPH, what I want to stress is because it is an acute emergency, and when we are faced with such a situation, the first thing what we should do is we should collect as many people as possible. So
very good. Call for help.
Yeah, shout for, rather than calling, shout for help. And once people are there, we have to relegate the duties to each one of them. Like even if there are 10 people, if everybody tries to do the same thing, then it's of no use having so many people. So somebody will have to take the lead.
Segregate the work.
Segregate the work.
Yes,
and at the same time, all the drugs, everything should be kept ready. We have to keep always a PPH kit ready, so
Correct.
that at the time of emergency, we are not searching for any of the drugs. So that is very, very important.
True.
Along with that, we have to find out what is the cause for PPH, whether it is atonic PPH or it is traumatic, because so many times there may be multiple factors. So there may be atony, but at the same time there may be traumatic factor also. So if we
combined.
Focus only on the atonic, so we may be losing so much of blood there because of the trauma. So we have to find out what are the other causes for PPH. That also has to be ascertained, and it should be a multi-pronged approach for the management of the this thing. So in this case, suppose if it's a case of atonic PPH, so one of the methods of controlling the bleeding is like when the medical methods fail, when the drugs don't give the required results, then we may have to go for the balloon tamponade. So we have the Bakri balloon, which is specially designed for creating the tamponade within the uterus. So we can insert the balloon inside the uterus, and then we'll distend with at least 300 to 500 ml of the saline. So that will put pressure on the blood vessels and it will stop bleeding. So we can keep the balloon for at least 6 hours minimum, or maybe kept up to 24 hours. But Bakri balloon is quite costly. So we can simply make our own balloon, that is the condom catheter. So that also is quite effective. So we can go for that condom catheter also.
Yes, ma'am. Correct. The condom catheter is easily available also, can easily be made.
Prepare at in our any center, it can be prepared.
Yeah, even in the primary health center also they can prepare, and they can definitely put it, and then they can refer it to higher center. Excellent, madam. Thank you.
Hardly it requires one Foley's catheter and a condom. So
True. And some saline to infiltrate. That's all.
Yeah.
Excellent, madam. Thank you,
Sir,
ma'am.
I want to add something. Before
please.
you do all these things, we have to get one cross-matching sample and send somebody to get PRBC immediately.
Yes. Correct. Arranging the blood is very, very important as a part of management of PPH. We cannot compromise in blood and blood components. That is very good factor, madam. Dr. Aarti has added. Next, we'll move on to the fifth question. That is, what is the mechanism of action of balloon tamponade? Dr. Kalavati, if you are there, can you take this question?
Yes, I'm there. Can you hear me?
Yes, ma'am. Yeah, ma'am.
Yeah.
We can hear
Mechanism of action of balloon tamponade is similar to the mechanism of action of uterine packing, what we used to do before with the gauze. It compresses the blood vessels and occlude the bleeding surfaces of the uterus. It is a hydrostatic balloon catheter which exerts direct hemostatic pressure, that is the tamponade effect, to the open uterine sinuses. So whenever we are using a tamponade technique, there should be counter pressure from the uterus that is achieved by starting about 20 units of oxytocin in 500 ml of normal saline at a rate of about 40 drops, depending upon the uterine contractions, what is needed. We can increase the drip rate.
Okay, okay. Thank you, madam.
Okay, sir.
Suppose if there is a situation where if the OT is busy and if the ectopic pregnancy patient is in shock or if any surgery is in progress, then what he will do? Dr. Shruti or Dr. Minal?
Yeah, I think Dr. Shruti is not able to make it, so
Yeah,
I'm
ma'am.
going to take her place
Yeah.
because, as they say, the show must go on.
Yes, yes.
So here we have this situation when the balloon is not working. That is a negative. That means the bleeding is still continuing, or the bleeding has already occurred before the balloon was in place, and the causes could be either a coagulation defect, or um, it could be that the uterus is torn, and we need to uh, go in for a surgical repair. But here the situation is that
The
the
OT is
OT
not
is
available.
busy. Ectopic pregnancy is going on. So what to do in that situation? Because all of us know we have to do the maybe the compression sutures, internal iliac ligation, and embolization also is not available in many a setups. So the only things possible would be a bilateral uterine compression, which we are all of us are very well versed with. The only thing I would say is external aortic compression, which we don't use so much. It is quite underrated and underused in OBGYN. And I was quite surprised when one of my PGs, she mentioned external aortic compression. It's quite common in emergency medicine practice. They do it. And it will, if done properly, it will help the patient during transport also, because it decreases the blood supply to the pelvis, and therefore the pelvic bleeding would be minimized, and also it increases the blood supply to the vital organs like the heart, brain, lungs. So external aortic compression should be practiced even during transport, and then the NASG, or the non-pneumatic this garment.
Very true, madam. Well,
So
well said. As you
yeah,
said, the balancing decision, the most important decision here is to reinforce the medical management with the surgical management to save the life of the mother.
Sir, I
So
want to
now,
add something here.
yeah, ma'am, please, you can.
Sir, before doing this, we can definitely try SR cannula for this. And it is very well working, actually. Dr. Samarth Ram's discovery it is, and it is very good in PPH. And even after normal delivery, we can use this cannula.
Okay.
These are the
Okay, ma'am.
Am I audible? Am I audible?
Yes, 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 yes. You are audible, ma'am. That is
Sir,
one more
SR
method
cannula is
of
an option, sir.
controlling the PPH. As you said, SR cannulas can be inserted in
Yes,
the uterine
definitely,
cavity and apply some suction. So definitely the uterus will create a negative pressure, and that will compress that will approximate the anterior and posterior wall, and that will stop the bleeding. Very well, ma'am. Thank you, ma'am. So now when the OT is available, what next? Dr. Purnima?
Yes. So
Yeah,
now
ma'am.
the OT is available. So
Yes.
in this case, we can use uterine compression suture, that is brace sutures. It's one of the conservative surgical management for atonic PPH. Rule out other causes when anesthesia is there. Examine her in a good light to rule out other vaginal and cervical laceration, and ensure that the systolic blood pressure is more than 100 mmHg. Then a patient should be placed supine. So there are different varieties of brace sutures like B-Lynch and the Heyman sutures. B-Lynch is preferred in C-section patients where the incision is taken, as we all know, it should be placed in the obstetric theaters also to quick glance when needed. And Heyman suture without hysterotomy we can plan in case of normal delivery, and if there is an atonic PPH which is not controlled by medical and other conservative management, then we can plan for Heyman sutures. So before going for this other surgical procedure, this conservative management for brace sutures will help in preventing the reducing the PPH and further surgical options and
Yes,
also
ma'am.
hysterectomy, avoid hysterectomy in patients.
Yes, yes. Thank you, ma'am. What suture material you are using, ma'am?
So, it is better to use absorbable suture, as it is found with a non-absorbable suture there is bowel herniation. So absorbable
Yeah,
suture,
polyglactin.
polyglactin like Vochromic Catgut and monocryl, which should be round body.
Yes, yes. Thank you, madam. The absorbable suture material has to be used. Okay. Next is, if the brace sutures are not working, then what next you can do? Dr. Shobha? Ma'am, Dr. Shobha?
I think Dr. Shobha ma'am is not available.
Yeah, Vinayak,
So,
doctor, I think you can take the question of this.
yeah, if all the, like, we have to go stepwise vascularization. If the sutures are brace sutures are not working, we can go for ovarian artery ligation also. Even if that is not working, the best method is like intra-iliac artery ligation. As even Prabha Desai ma'am also said, like everyone should be well versed with the intra-iliac artery ligation. Like bilateral ligation results in 85% reduction in pulse pressure and 50% reduction of the blood flow, and the arterial flow converts to the venous flow. The coagulation is facilitated and bleeding is reduced, and the patient's life can be saved. Technically difficult initially, but I think with practice we can do it. And even FIGO recommends intra-iliac artery ligation as one of the options to rapidly control PPH when medical and non-surgical approaches and compression sutures usually fail. FIGO also recommends that all obstetricians familiarize themselves with the intra-iliac artery ligation, the location and techniques of its ligation. As everyone know, like we have to ligate it 2 to 3 centimeters below the division of the common iliac artery. And in these cases, if the patient responds to intra-iliac artery ligation, and we are able to save her uterus. Sir, I think
Thank
we
you,
can
Dr.
move to the
Vinayak.
next
As you
question.
said, it is the first stepwise devasculation first, like uterine artery ligation, ovarian artery ligation, then the bilateral internal iliac artery
Bilateral
ligation. Though
artery ligation.
initially you feel it is difficult, by practice you can master it, and definitely you can save the uterus and life of the mother. Thank you, Dr. Vinayak. We'll move on to our next question. What is the standard blood transfusion protocol? Dr. Aarti? Aarti ma'am, are you there? Dr.
Hello?
Aarti?
Yes, I am there.
Yeah, ma'am.
Yeah.
Blood transfusion protocol, ma'am.
Sir,
Standard.
we have to ask for PRBCs, fresh frozen plasma, platelets, and cryo. PRBC, FFP, and platelets are given 6 units each, with the cryoprecipitate 10 units. Sir. And same can be repeated if a repeat shot of blood is required. Along with it, again, tranexamic acid can be given. After 30 minutes, the bleeding is not stopped, 1 gram. And again, we can go for 4th round of PRBCs, FFPs, and platelets.
Yes, ma'am. Yes. Yes, ma'am. As you said, one packed cell in a massive transfusion, one packed cell and 3 FFP is the ratio. Some would say 1:2. But when you transfuse, go for massive transfusion, again, fresh frozen plasma or platelet has to be transferred along with the packed cells. Yeah. Thank you, ma'am. Now let's move on to the case 2. She's a case of para-1 living one.
Sir,
with a
if I may add, sir.
Yeah,
So
yeah,
the
you can, ma'am.
ratio is 1:1, sir.
1:1.
Yes, PRBC
Okay,
to
1:1. Even okay.
Yes.
Okay, ma'am. Thank you. Now move on to the case number 2. A case of para-1 living one with previous vaginal delivery, 12 hours back, referred with a history of traumatic PPH, cervical and vaginal laceration with PAC in situ. On examination, her heart rate is 120 beats per minute, blood pressure is 90/60, and respiratory rate is 28 beats cycles per minute. Her saturation is 97% on room air. Pallor is present. On examination, her uterus is 20 week size, well contracted. Locally, PAC is partially soaked. Then the question, just outline broadly the steps of management in her. Dr. Nagratna?
Yes, sir. Thank you, sir.
Yeah,
So
ma'am.
this is a case of traumatic PPH. As we are seeing, the patient is already in shock. There is tachycardia, hypotension. The saturation is also low down. but they have sent with the pack, vaginal pack, and it is partially soaked. So first is we have to start the resuscitation. That is the ABC of resuscitation. So airway should be kept patent. Then we have to start oxygen. Then fluids should be started, and simultaneously we have to send investigations, mainly the CBC, renal function test, electrolytes, then coagulation profile. Along with that, ABG is also very, very important. And so we have to, because she has lost blood and HB is already 6 grams, so we have to arrange for blood and blood products that has to be transfused at the ratio of 4:4, that is 1:1 ratio, FFP, RBC, and the platelets. And then we have to take, because there is a traumatic PPH that has to be repaired, we have to take the patient to the OT, and then we have to repair this thing.
Thank you, ma'am. As you said, you stabilize the patient first, and since it is a traumatic PPH, you have to take her once you stabilize, arrange transfusion, and take her for OT for
Yes,
repair.
sir.
Thank you, ma'am.
Stabilization,
Thank you.
arrange for blood, and the investigation should be ready, like whatever the condition of the patient, we should know.
Yes, yes. Thank you, ma'am. Next, move on to the next question.
Sir,
How should we
I would
manage
like
this
to add,
situation?
sir, I would like to add here, as
Yes,
patient
ma'am.
is already in shock, we need to call for help. Call for help, that is
Correct,
4
correct.
components should be included. That is call for communication, resuscitation, and monitor and investigation, which should be started simultaneously.
Yes, yes. Call for
Yes,
help
ma'am,
is
that
the
was
first.
already highlighted, because in
Yes,
the
ma'am.
last case only, whenever there is any
Yes,
case
yes.
of PPH, the first thing what should be done is
Call
shout
for
for
help.
help. Yeah,
Yes,
yeah.
yes. Yes,
Okay.
yes.
Mm.
Next, Dr. Kalavati, how should we manage this situation? Ma'am, can you elaborate? Dr. Kalavati?
Yeah. Can you hear me?
Yes, ma'am.
Because I am not very this thing. The case he has put, you people have put up. It says para 1 L1.
Yes,
So
ma'am.
maybe the most commonest cause, maybe they have tried some forceps delivery or something, because it is associated with vaginal tear, where the apex cannot be reached.
Ma'am, on cervical exploration, there was cervical tear of 6 to 7 centimeter at 6 o'clock position.
Yeah, that
And
also was there. Along with that, there is a vaginal tear where the apex could not be made out. You
could
have
not be
written.
released.
Yeah, I feel this is a case where there is involvement to the lower uterine segment or something. So we have to find out first whether there is any involvement of the vagina leading to the lower uterine segment or something. So basically, we have to differentiate whether it is only the involvement of the vaginal vault or vaginal vault along with cervical tear, you say. So it looks like a case of complete calporexis.
Okay.
Yeah, I felt like that.
Yes, ma'am. Yes, ma'am.
Then first, when this is there, we have to next go and find out whether there is any hematoma in the, whether there is a supralevator or infralevator, this thing to make out. Then we have to go for the imaging techniques, ultrasound, computed tomography, or MRI to see the location, size, extent of hematoma and monitoring. Then laparotomy has to be thought about. First thing is to, along with the resuscitative measures, I feel the hematoma drainage and to identify if there are any leading this thing. So for internal cartilagation, because para 1 L1, so instead of going for this thing, one uterine artery embolization also can be tried. And because it is a vaginal this thing, we have to find out if there is any involvement of the lower uterine segment. Do a laparotomy and find out. So I would like to go for a repair, and then along with the resuscitative measures.
Yes, ma'am. Thank you. As you said, you stabilize the patient first and do an exploration under anesthesia. If bedside ultrasound is available, definitely you can do it.
Yes, I would like to know. Yes,
Yes.
definitely.
Yes, ma'am. Yes. Thank you, ma'am. Thank you. Next, we move on to the next question. Like, what are the challenges and alternatives to this? Dr. Milan?
Yeah.
So we are talking about traumatic PPH here, and as Madam has said, colporexis or even the tear is extending up to the uterus, uterine tear, or it could be a LSCS complication also. So here the uterine artery would have retracted, and it is difficult to trace. And again, when we are trying to open it, we cannot trace it, or it would have retracted. Chances of injury to the ureter. And what we are going to try to do is try to repair, if possible, any traumatic tear if it is there. Devascularization, of course, internal ligation, bilateral. What I would, and it could be a supralevator or infralevator hematoma. So what I would like to stress here is it could happen in the immediate postpartum period also. Patient complains of severe pain, pelvic pain. So that could be a supralevator hematoma, and those only presenting complaint would be a sudden severe pelvic pain. And with an infralevator hematoma, of course, it would be visible pervaginally. So whenever a patient complains of pain, she should not be disregarded. An examination, at least an examination, local examination should be done. And if it is presumed to be intra-abdominal, then we can go ahead with CT scan to rule out. And then repair of the supralevator hematoma, mostly it should be done per abdominally only. So laparotomy has to be done. And infralevator, of course, it can be, if it is visible, then we can give ice packs or local. Of course, if there is a big hematoma, we have to incise and drain it, and ice application of ice packs, and then packing later on local. It will increase the pressure and
Yes, ma'am. Yes. As you rightly said, ma'am, whenever the patient comes with a pain of abdominal pain or rectal pressure or vaginal mass, definitely you should suspect a supralevator hematoma. And if she comes with vaginal or vulval pain and swelling or episiotomy swelling, you should think of infralevator hematoma. So then you can treat her accordingly.
accordingly.
Okay.
Yes.
Yes. Thank you, ma'am.
Okay. Thank
Now
you.
we move on to the last case number 3. She's a Gravida 5 Para 4 living 4. Vaginal delivery is 10 days back. She's afebrile, but her pulse rate is 118 beats per minute. Reported with a severe bleeding PV on day 10. In our emergency, her pulse rate is 134, BP is 110 by 60 millimeters of mercury. Now the question is, what is the significance of these vitals? Ma'am, Dr. Aarti, ma'am?
Yes, I'm here.
Yes, ma'am.
Actually, her pulse is more than her systolic BP. And
Yes,
this indicates she is not stable. She is in shock.
Shock.
Shock index is heart rate divided by systolic blood pressure. And if it is more than 0.9, means heart rate is more than her systolic blood pressure, then it indicates that she is in shock and she is suffering from severe PPH. And then she should be managed vigorously. So this is the importance of checking the vitals along with temperature and saturation.
Yes, ma'am. Thank you. The medical management failed, balloon tamponade failed, uterus atonic. Decision has been taken for hysterectomy. And the final last resort is hysterectomy only. To save the life of the mother, you can sacrifice the uterus. Now we are coming to the last and final part of the webinar. That is the take-home message. So postpartum hemorrhage is a serious life-threatening obstetrical problem, a forerunner in all our near-miss audits. The responsible fearsome 40s are tone, trauma, tissues, and thrombin. Risk factors for PPH are known, but not always possible to prevent it successfully. Major cause of mortality and morbidity is too little is done too late. The golden hour, early recognition and management is essential through hemostasis algorithm. resources of even well-equipped and staffed units may be stretched and avoid mistakes during emergencies. Thank you, ma'am. I thank all the participants and the panelists for this wonderful discussion. I thank Dr. Vinayak for elaborating on PPH. Over to you, ma'am.
I thank the organizers for giving me this opportunity. Thank you so much.
Dr. Deshmukh ma'am is there?
She is not available.
So,
Yeah.
big round
I
of
think
applause for both the moderators for nicely moderating the panel. And at the same time, big round of applause for all the panelists also,
true,
putting
sir.
their, making panel very interesting and fruitful.
Thank you, sir.
Yes.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.
Thank you, sir. Thank you to both the moderators. It was a wonderful panel discussion. Thank you to all the panelists. Thank you to Corona for providing the platform. Thank you to my co-coordinators for the program. Thank you to all the speakers. And last but not the least, thank you to our program director, Dr. MC Patel, sir. Requesting all of you to kindly please vote and support MC Patel, sir, in the upcoming election. We are really looking forward to all of your support. Thank you so much. Have a good night, everyone.
Thank you, ma'am. Thank you.
Thank you.
Shivani, we can conclude.
Okay, sir. Thank you.